We are so excited to see everyone here this morning, bright and early in Chicago. Thank you for hosting us, Chicago. My name is Donna Klassen. I am the co-founder, one of the co-founders of Let's Talk Menopause, and I am also a therapist doing skills-based therapy in private practice, and I've worked in reproductive mental health for years. So we are so excited that you all joined us today, bright and early in the morning, for Menoposium, our second annual Menoposium 2024. And we're gonna get started by watching a little video. And what I want you guys to think about is, one, what decade this was in, or year. Two, is it funny? What are your thoughts about it? Because it's a really interesting video. And my thoughts about it have sort of changed throughout, but I'm going to be curious to hear about what your thoughts are about the video. So, Jessica, take it away.
Am I going through menopause? You bet I am. But you'd never know it, thanks to the new tropical fruit smoothie at Jack in the Box. With my hot flashes blindsiding me, I need to cool off fast. That's why I love this delicious combination of mango, banana, and frozen yogurt. It keeps me cool, refreshed, and best of all, it helps me from going all, you know.
Street rat crazy?
Yeah.
Okay, so who here thought that that commercial took place in the 1960s? No one? 50s or 60s? A couple people? Who thought it took place in the 1970s? Nobody? 1980s? Okay, a couple people. Did people watch this before? 1990s? Okay. 2000s? Okay. 2020? It could be. What do you guys think of it? Anyone? People can just start out. What are your thoughts? Good, bad, weird? Weird? Okay. So I've never seen a commercial about menopause before. Have you? Until very recently? Okay. The last couple of years, right? Before then, women were not looked at in midlife and beyond. And that is time to change. So Let's Talk Menopause was formed because women were not getting the health care they deserve, the information they need to make choices that are really important for their health, both short-term and long-term. So our mission is to change the conversation around menopause so women get the information they need and the health care they deserve. We launched with over 300 subway ads in New York City. It's not just in your head, in both English and Spanish. We have an active website that that's jam-packed with information that's accessible, translated from doctors and providers who are experts in the field, but for real people who need to understand what's going on with their body, because it's not just one issue. It's a complex issue that involves many body parts. It's also at a time where our lives are transitioning, and so it's really important to get that information. We also have a podcast. We are on our second season, hosted by Stacey London, with many of the people in the room guests of our podcast. We're active on social media, which I think a lot of you all have seen. And we have things on the website like our symptoms tracker and other various things, including our public ad campaigns. I also just want to say people have on their tables something about the Menopause Research and Equity Act. That's something that we've also been doing, working with a coalition of women and people and organizations to get more money for menopause research. And I think if people saw the news yesterday, there was a Senate bill, a companion bill that just got introduced with Halle Berry and many Senate Republicans and Democrats and women. And that bill is now a companion bill in the Senate. So people can go to our website, and you can literally write to your member of Congress through our website. So go to our advocacy page on our website and sign up. Before we get started, I want to acknowledge the people that helped us get here. Most importantly, our sponsors. We want to thank Bayer, Versali, Pfizer, and Astellas. And our media partners, Hello Menopause, She Media, and Flow Space. I, of course, want to thank my partner, Samara Daly, the other co-founder and board chair of Let's Talk Menopause. Thank you so much, Samara, for all that you do to help make all of this happen in reality. Jessica Levin, our Chief Program Officer, who has put together a program for you that you are not going to forget. It's innovative, it's exciting. We have the best-in-class doctors here and providers. And she's put together a remarkable show, as well as our menopause talks. That's the other program area that I failed to mention. We have over 25 menopause talks on our website that are free for you to go through, because not everything is going to be covered here. Okay, so I just want to, there's a whole bunch of information on our website. So thank you, Jessica, for all that you've done and do. Marie Capozzi, our Chief Operating Officer. We just got one this year, because Let's Talk Menopause is the little nonprofit that could. We are putting together an amazing team, and Marie has been this wonderful addition this past year. And she put together all of the logistics around this event. It's fantastic. Stacy Geller, who is not here today, but she is our creative designer. So all that you see here is her work, and she puts our ideas into ways that's exciting and vibrant and young and youthful. And Kaylee Heyman, our social media manager. Ada Moses, who does not have a job title, but she helps with everything, and she's absolutely fantastic, and she's working back there. Judy Sage and Adit Vukatana, who's our advisors. Christopher Gillespie, got that right, who's our public relations director. And of course, our hosts and valued board members, Tamsen Fadal and Dr. Judith Joseph, and all of our board members and medical advisory board members. I want to also just thank all of our tremendous panelists. I think all of you, when you looked to see who was speaking, were sort of like, wow, what an incredible group of women. And we really appreciate you taking the time out of your busy schedules to come here and help us with, Let's Talk Menopause, do the work that we can do. And we're here to support you to be able to get your message out. Because sometimes the message is that doctors don't know. Well, not these doctors. These are the, the leaders and the forefront of the menopause movement. Some have been involved for many, many years, and some have just started, but with an expert of a wealth of knowledge. So thank you to our panelists. Can you move it up a little bit? Thank you, my dear. So why are we here? I think I talked about, what the problem is, right? Women are not getting treated. Jess, the next slide. Medical disclaimer. So basically, this is not medical advice for you personally. So please also, when you think about your questions that you're going to ask, try to keep them in the most general way. This is not a substitute for medical advice. A recording disclaimer. We just ask that you don't videotape without our permission, and then slides. Most of the slides are our property, and we ask that you don't reproduce without our permission. Okay? So 75 million women are in perimenopause, menopause, or postmenopause in the United States. 75% of women who seek medical care are left untreated. 80% of OBGYN residents admit to being ill-prepared to discuss menopause. So, when people want to start treatment, they think, I'm going to go to my OBGYN. Of course, not these GYNs, many of whom, obviously have been doing this for a long time. But a lot of times people expect to go to their doctor, their provider, and no. But this is why it's really important for every single person to get educated around this issue so that you can be your own best advocate. We have two fantastic hosts. Tamsen Fadal. I think all of you have heard of her, know her. She is an accomplished journalist, an award-winning journalist, speaker, author, podcast host, and menopause advocate. She's dedicated to championing women's stories in being bold in midlife and beyond. She's got a passionate social media following. She shares tips and advice, helping women move into their next chapter with confidence, courage, and curiosity. She's the author of multiple books, including one that's coming out soon on menopause. So Tamsen, if you can come up and join us.
Hi here. Thank you, thank you. This is exciting.
Yeah, it is exciting. Tamsen is also a board member and ambassador of Let's Talk Menopause, and she has been a friend and ally of Let's Talk Menopause since we started. Now I'm also going to bring up Dr. Judith Joseph. Dr. Joseph is a board-certified psychiatrist, educated at Duke and Columbia. She's a principal investigator at Manhattan Behavioral Medicine, a clinical research site, so she does research on menopause and other areas. Through her global travels, she is committed to diversity and advocates for mental health and inclusivity. Dr. Joseph's impactful social media presence, making mental health knowledgeable and accessible to people, her knowledge accessible and engaging. She's an award-winning content creator and a celebrated figure in psychiatry. Welcome, Dr. Joseph. Dr. Joseph is also a board member and a friend of Let's Talk Menopause. So I'm going to have you all take it away.
Okay, great.
Hi, everybody. Are you guys awake? Because I had 1 cup of coffee. I'm going back for more. I'm excited to see so many familiar faces and so many new faces, so thanks so much for being here today. I want to clear one thing. We did not plan this.
No, we did not.
Get that off the table now. But we both happened to pack this, so we just wore it. Anyway, we have a lot we're gonna share today. We're both going to be doing a couple of panels, and I'm excited to be here.
I am too, and many of you don't know this, but Tamsen and I first met because we were auditioning for a show. We won't say the name of it, but they were pitting us against each other as like frenemies. And then we thought, why don't we just become friends? And we've been friends ever since. The show did not work out, but you know, it's just a testimony to when women stick together, we can accomplish so much. And you are all here to learn, to receive, but we just want to encourage you that when you do learn something, share it. So reach out to a friend, create community, because that's what keeps us stronger together.
Yeah, it really, really is. You know, we've got a lot we're going to cover today, and we're going to have Q&A with most of the panels, so that's a good thing. So we're going to start out with what to expect, perimenopause, menopause, and beyond. So that's the first panel we're going to cover.
And then we're going to go into the facts about menopause and hormone therapy, so you want to take notes on that.
Yep, be a short break, a 15-minute break, and then we're going to talk about the fact that it's not all in our heads.
This is so important because many of us were told that, you know, these symptoms are related to depression, but there's a lot of confusion. We want to clear that up.
And then finally, it's time we discuss the vaginal, sexual, and urinary symptoms of menopause. And again, we'll have Q&A throughout. Make sure you don't ask your own personal medical questions, just because the doctors are not going to be able to answer that. But they were going to do the best they can to answer whatever questions you throw at them. Okay, I think we'll get started, right? All right, so we're going to bring up the first panel, and this is one, what to expect when perimenopause, menopause, and beyond. And just kind of an overview, talking about some of the questions of women being blindsided, of course, by perimenopause, menopause, and the symptoms, how they all are defined, common symptoms, and how we can find the menopause care that we need. So first I want to bring up a doctor, oh, gosh, come on up, let's not stand on ceremony. Dr. Monica Christmas is the Associate Professor of OBGYN at the University of Chicago Medicine. She directs the Center for Women's Integrated Health and their menopause program. And Dr. Christmas takes a holistic approach to patient care, exploring traditional and non-traditional treatment options. Welcome. Dr. Lisa Larkin is a women's health internist, menopause, sexual medicine, and medical breast expert, physician, and educator, founder and CEO of Ms. Medicine, and currently the president of the National Menopause Society. And more information on these incredible experts and doctors in your folder. All right, let's sit down. I don't know how to be too formal. So we talked a little bit about what we're going to cover in this panel, because I know there's always a lot of confusion. I know you all get these questions anytime someone comes into your office, stops you on the street, asks you on Instagram. But I want to talk a little bit about why this was something I thought was really, really important to discuss. I had no idea that I went into menopause. I landed on the floor of the studio, and I was hot. My heart was racing out of control. I didn't know what was going on. And my journey, I think, is not so unique. I didn't know what was happening. Brain fog was debilitating. That was probably my biggest symptom if I look back over the course of what was going on in my 40s. I'd gone through a divorce thinking, it's just stress. Just stress. I just got a lot of stress, and didn't realize what was really happening to me. So my story is not unique. There's no question about that. But I want to start with you, Dr. Larkin. Why do the vast majority of women entering perimenopause or menopause without information? They enter it with no information, and oftentimes see doctors that cannot really help them.
Right, so this is such an important question, and I like to lump the categories because there's many reasons of why this is. The first really started with the Women's Health Initiative, so that obviously we're going to hear more about. I'm not going to go into details of that. But in 2002, everything changed, and what happened then was with the initial publication created fear among patients, but also among doctors. And I can tell you I was already practicing about a dozen years at that point, and I was doing a lot of menopause prior to the WHI. And at that point, doctors stopped prescribing hormones. And what else happened is we stopped teaching doctors about hormones. So since 2002 till now, we have a generation of physicians that really have been inadequately prepared to take care of midlife women. You add to that just fundamental ageism. You've all heard also of the lack of research and investment, which now I'm so excited is really changing. I really see that we're at a pivotal moment in the women's health space. But fundamentally, we've been neglected by research, education, and what that's done is left women who already at midlife fall through the floor, right, in a quandary. The other last thing I'll just say is our healthcare delivery models in the United States don't work when it comes to midlife women's health. So who owns women's health? Nobody owns women's health, right? Women age through their entire lifespan. And so this idea that either OBGYNs or primary care doctors owns women's health is not right? We actually need to work collaboratively. The best model of care for women is OBGYNs and primary care doctors working together, but our system doesn't really support that, right? So then you have the midlife woman who is done childbearing largely in their 40s, isn't seeing their OB very often. They don't have a lot of health issues yet, so they're not seeing me as their internist very much yet. And that 40 to 60-year-old woman has the least points of contact with healthcare providers. And then when they do see their healthcare providers, they're told that menopause is natural and they should just suffer through it, or that hormones are terrible and scary. And so women are really left to fend for themselves. And it's really generated where we are today, right? Which is women not getting the care they need or deserve.
I think that there's so much to dive into, and we'll do that throughout this panel. But Dr. Christmas, I want to have you define perimenopause, menopause, and postmenopause, because I think a lot of us don't know where it starts and ends. Can you talk about that?
Yeah. So perimenopause is let me start first. I'll say the median age of menopause, and we define it as not having a period for a full year, is about 52. Some people say 51 and a half, whatever, 51 to 52. The range that 90% of women will fall into is between 45 and 55, right? We start to experience symptoms related to hormonal fluctuations up to 7 to 10 years, depending on what you look at, before you actually go through menopause. So it's quite normal in your late 30s, early 40s, definitely in the mid-50s, to possibly start experiencing troublesome or bothersome symptoms. And there's not one menopause syndrome that everybody is gonna get. Some people are really fortunate. They don't have very many symptoms at all. And then there are other people that have every symptom that you could probably get. And there's everything in between. That perimenopause time frame is that 7 to 10 years or so that you possibly are symptomatic. Could be hot flashes and night sweats. It could be noticing that your metabolism is changing and not in the right way, okay? Mood fluctuations, I think, is one of the most common symptoms that I get in that perimenopause time range, because people don't understand where it's coming from. The irritability, and it could be different things. Some people express, I personally had much more sadness than anything. And I'll share that with patients and they'll say, no, that's not how I describe it, right? I'm irritable, I'm angry, and I'm gonna tell you about it. And it's frustrating too, because at this stage, many of us are at pivotal points in our career. We have other people that are reporting to us, we're in leadership roles. And if we are, having difficulty managing emotions, that is extremely troublesome. It was for me, because I don't want to be crying every time somebody says something to me, and that's what I was doing, or still am, actually.
You're so right about. I saw a friend last night, and she goes, "I'm weepy," and I said, "Weepy? That's a good word. That describes it all."
Or people say, I'm not depressed, right? But then they tell me in the next breath that I don't have energy to do the things that I once did. I just don't not as involved, but I'm not depressed. But that's anhedonia. That's a form of depression.
Right.
So there's that. And then menstrual changes. I'm a minimally invasive gynecologic surgeon. This is the time when most people are coming to see me, because if some people are fortunate, their periods get shorter, they get lighter, they politely space out. Some people are even better than that. It's like, what's today's date? I forget, May 2nd or 3rd. It just stops and never comes back again. But then there are a lot of people that their cycles get closer together, heavier, longer before they go away. And so, again, all of these things happening in a time frame where, as Dr. Larkin said, people may not be recognizing it. Well, you're still getting your period, so you're not in menopause, it's not that. Or better yet, which they're very not helpful, somebody actually will listen and say, I'm going to check labs for you. And they'll check labs and they'll say, oh, they're perfect. You're not menopausal, and leave. And that's why labs aren't helpful, because those labs, those values, those hormone levels are fluctuating.
Yeah, I do want to go into that. I want to jump real fast, though, into that kind of transition into menopause. So we talk about that long period of time of perimenopause, and then when you know you're in menopause.
So postmenopause is just thereafter, right? When we are children or whatever, you're prepubescent, you're in that phase of life, you start getting your period, you're in the reproductive phase of life, and once those cycles stop, or because your ovaries are no longer producing the hormones that they once did, natural process, you're in the postmenopause phase of life. So I think people think about it, though, in the fact that symptoms start to get better.
Sure.
So then they think, oh, I'm no longer having hot flashes anymore, so I must be done with the process. You're done with some of those symptoms, and that's a good thing. But that doesn't mean, it just means that you're done with the symptoms, but you're still postmenopause.
Well, yeah, and Dr. Larkin, I'll have you address this part. That is, I hear a lot of people like, I went past that. Every once in a while I hear somebody do that. But you're still postmenopausal.
Right. So I'll back up 1 second just to say, the perimenopause is the time when I see a lot of women really getting blown off by their physicians, right? Because that's harder to define for doctors, right? So your bleeding hasn't stopped. We can define menopause really easily. But what I talk to women about all the time is, we should trust women. Women can tell you when they're perimenopausal. Their symptoms, as Dr. Christmas said, can be very different woman to woman, but women know. I mean, they may not even really be having changes in their cycle yet, but they are a little more fatigued. They are noticing they're having more breast tenderness and mood stuff right before their periods. They may be having intermittent symptoms. Their libido is lower. And I can't tell you the number of times that patients come in to see me and said, my doctor told me that I couldn't be perimenopausal yet because my labs were normal, right? And as you just heard, laboratory testing in the perimenopause is not very helpful. But back to your question, which really is, right, so the reason that this is such an important stage of life, right, and so women can have children by choice, but all women that live long enough will go through menopause. And so, yes, it's natural, and there's this debate of whether or not we're over-medicalizing it, which I won't get into, but the issue is there are huge physiologic consequences of what's happening with menopause, huge. So it's not just the stopping of the menstrual cycle, right? This is all of the consequences of the change in our hormonal milieu. And now that women are living 30 to 40% of their lives in the post-menopause, we're seeing what the consequences are of that much longer. And so again, even though the definition is no menstrual bleeding for 12 months, the impact of that change in hormones lasts the rest of our lives. And so so we have to be very thoughtful about what is healthy aging and what is healthy living in all of that time beyond menopause, beyond that last menstrual period.
Right, right. You've both addressed it, but let's go back to the testing for perimenopause, menopause, because there are doctors that will do a test, right? Is there any time that a test works, makes sense during the perimenopause period? And I know your hormones are fluctuating all over the place. If you've hit menopause, is it helpful in any way? Because that is the number one question that I get.
When, if there are atypical symptoms or there are other things that are not typically related to menopause, then checking things like your thyroid function testing is warranted, looking for other potential causes before we just say it's that. Usually if you're in the age range, you're having typical symptoms, but checking the labs like your estradiol, your FSH level are not particularly helpful to know. When it is helpful though is if I have a 25-year-old that's coming in and having those symptoms and not having a period, because now I want to know, is this premature menopause? Is this polycystic ovarian disease? Is this some other endocrine something going on? So I think it's helpful then, but if you're in the average age range and you're having typical symptoms, then we need to manage those symptoms and help you attain a better quality of life. And it's not related to what labs are.
Right, and I just follow up with that to just say, right, like we don't use hormone levels to direct your care. We don't actually need them, right? So we can tell you, women can tell you when they're perimenopausal, their hormones are all over. I don't need a blood test to actually tell me that. Trust women, they know they're perimenopausal. In the postmenopause, we know what their hormone levels are going to be, and we don't use, with the exception of our very early menopausal patients, where we may use blood levels to target appropriate hormone levels in our 30 or a 35-year-old. But in general, we're not using levels to titrate hormones post-menopause, and so they're not very helpful for the average woman, as you heard.
We address symptoms somewhat. There's lists and lists, and every time I think I know the whole list, there's more that seem to be added to it. Let's talk, Dr. Christmas, let's talk more about the symptoms and how women can differ in their menopause experience.
I'll say, and I might get like, nobody has any rotten eggs or tomatoes in here, right? Menopause, from the most part, is inextricably tied to the aging process too. And so when we start adding all of these symptoms down, it's hard to sometimes differentiate. Some of them we do know, absolutely. This is related to hypoestrogenism. But other symptoms, it's like, well, maybe not, or it could be a byproduct of something. So, the most typical things that most of us probably know in the room, the hot flashes, the night sweats. The night sweats can be particularly troublesome if they're disrupting your sleep, right? That can make that brain fog and fatigue and malaise a lot worse too, because certainly if you're not sleeping, those things are going to be worse. So if we think about moving down the body too, aches and pains, joint arthralgias seem to be more prevalent too. Dr. Larkin touched on changes in libido. Sometimes that is related to some of the vaginal changes that can happen. Our vaginas become thinner, drier. The glands in the area make less secretions as well. That potentially could lead to pain with intercourse or bleeding, as well as some urinary symptoms like urgency, frequency, recurrent urinary tract infections. I know this all sounds miserable. Please don't get up and leave. Metabolism changes, as I said, and again, much of we start to lose more muscle tone if we're not doing something about it, right? And that loss of muscle sometimes results in increase in fat. And that fat deposits in one of the worst places that I think it could go, this midsection here. Yep. So from a vanity perspective, I don't want it to go there, but from a health perspective too, that's one of the worst places for it to go, because that increases our risk of all these other things like high blood pressure, diabetes, and the sequelae that can come from those things. Did I miss any?
No. But
all right.
There's more. Let's talk about some of the different variations in the number of symptoms and in the severity of symptoms as well.
Right, so, not all women are miserable during menopause, right? I like to say it's the rule of thirds. About 30% of women will have pretty mild symptoms and not really be very bothered in terms of hot flashes and night sweats. About 30% will have moderate symptoms. And then there's those of us and the patients that I see most commonly in practice, right, are the women who are really miserable. And those group of women are having 7, 8, 10 hot flashes a day and at night. I can tell you I'm lucky to be in the category of 15% of women will have lifetime hot flashes. So I had chemotherapy-induced menopause very abruptly at age 49. And what we know is that the majority of women, but not all women, and there's some racial and ethnic diversity in kind of the numbers in terms of frequency, severity, and duration. Most women will start to resolve their hot flashes 1, 2, 3, 4, 5 years after that final menstrual period, but they can last much longer than that, specifically in certain races and ethnicities. But about 15% of women, and sadly I'm in that group, will have lifetime hot flashes that really can be very disturbing. Now, one of the other things I just want to mention is that brain fog that you mentioned that you have, right? So we know that for mood, that there's periods of time in a woman's life when she's more vulnerable, right? So when is that? That's puberty, postpartum, and the perimenopause and menopause transition. And what the common theme is in that period of time is when it's a period of time when there's big hormonal fluxes, right? Things are all over the map. And women in the perimenopause will often talk about their premenstrual mood changes being much worse during that period of time. The brain fog starts around then as well, and I have women coming in who say, you know, I'm afraid I'm developing Alzheimer's, I'm afraid I have dementia. I know there's a whole segment on this coming up later. In general, once women get to the other side, hormone levels now, as I said, are consistent, but they're low. A lot of that brain fog will clear up, and a lot of the mood things will actually get better. The last thing I'm just going to say is the big thing that we see in practice is the sexual dysfunction that happens. The vaginal atrophy, are now called GSM, and we're going to have a section on that too. That often starts much later. So women are very symptomatic. They know they're going through the menopause transition in that 1 to 2 years around their final menstrual period. But often they're not having much sexual dysfunction until 7, 8, 9 years after that final menstrual period, and that's when they're having the symptoms. And they don't always correlate it with menopause, and we know that that's an area where women are really undertreated again, and really we aren't doing a great job taking care of them. And did I miss anything?
No. All right, let's talk about this. Women, again, as I mentioned, often think they're done with menopause, but we talk about longer health implications to be aware of. Can we go down what the 3 big ones are?
So again, remember I said that menopause is tied to the aging process too. So some of these things are concerning for men as well. But certainly the relationship to not having the estrogen anymore sometimes can accelerate these things if we're not, again, doing something about it. So the big 3 areas, I like this slide, cardiovascular health, right? I'm going to jump over the middle one for a second and jump to bones. Risk of bone loss that could potentially lead to osteoporosis. And you think, well, why is that a big deal? Some of the sequelae that can happen with fractures, especially like a hip fracture, has a high morbidity and mortality. But even in just starting to lose height or to have that curvature in the spine, poses not just pain, but quality of life issues too, and being able to function in the way that we want to. And so many of the times, especially when we're talking about the lifestyle modifications that we all should employ, because it's always easy to say, I want the magic jelly bean. And it doesn't exist, right? I wish I could tell you that hormone therapy was the magic jelly bean, and it's not. It's great to help alleviate many of the symptoms, especially that middle section, the vaginal, genital urinary symptoms. It's great for helping with those pesky hot flashes too. But for some of these other things, we actually have to do our part too. And what we choose to put into our bodies to help fuel us to live as long and as independently and autonomously as we want is important. And how we choose to move our bodies and use our brains are important too. So we have to be very intentional about it. And it's a strategic thing for myself even too, of motivating myself to want to exercise every day and do all those things and to fuel my body with those healthy foods. And I think that's the best way to think about how we move into this next phase of life. And I'm hoping that not only talking about these kind of things when you're in the crux of it, but if we start to educate, just like we do about when you're going to get your menstrual cycle, right? There's all that information about it. You learn about it in school. We're getting kits and tool books, but we don't do that for that. Well, actually, we weren't doing it, but we're all here today getting it. But having that same type of preparation for this second stage of life, too.
I just follow up with that to just say this is the most important time for women to get good care. And I say all the time, right, I'm an internist. My patients have gotten old with me, so I have lots of 90-year-old patients that I'm taking care of now. But the gap when women fall through this 40 to 60-year-old range, I can tell you that's the time when if I can adequately assess your risk for developing cardiovascular disease, your risk for osteoporosis, your risk for breast cancer, if I can talk to you about those things and I can implement and help you implement lifestyle strategies to take care of yourself, I'm going to have the biggest impact on how you age and how long you live. My 80 and 90-year-olds, when I'm tweaking their diabetes meds or I'm tweaking their blood pressure medicines, the impact I'm having on taking care of them in terms of their life expectancy and how they're going to live is really, really small. So this is the time. Midlife women need to be empowered to make sure that they're really taking stock in their health and getting all of these things taken care of right now, because that's what's going to matter as you get to be 80 and 85 and 90. All of these things play in, and we can't do as much if you already have those issues as a
I'm going to go off the slide for a second and ask you a question. Do you have more women coming in and talking to you or approaching you with more information than you've ever had before? Because I
Absolutely.
Yes? Okay, that's
Absolutely.
great.
And
That's
I actually
great.
will
It
give a big
speaks to
shout out
this.
to many in the room who are doing a tremendous job on social media. There is noise that has,
Yeah.
and clearly all of the stuff going on the Hill and with our current administration is really doing it. But yes, the noise is out there, and more women are coming in talking about all these things.
I'll just say too, Dr. Larkin, something she said made me think about it too. As we're thinking about preparation and living our best lives, is also understanding what our risk factors are too, right? There are genetic risk factors, and sometimes that can be a scary thought too. If you think, my mom maybe had breast cancer, her mom did, I have a cousin that did too. I'm just going to forget about that because I don't want to think about it. I don't want to will these bad things. Or maybe everybody in my family's had cardiovascular disease. My dad had a massive heart attack or something when he was 45, and so did his dad. But maybe I'm already doing a little bit of things, but really understanding what your risk factors are so we can mitigate against some of those things, which many times we can,
And this goes back to what the failure of our health system, right? Which is, again, women aren't getting enough visits with their doctor. When they are seeing their doctor, they don't have a lot of information about the impact of menopause. But then as well, there's 7-minute appointments, or you only get in for your annual visit, and all of this important stuff. And it's my passion now is breast cancer prevention, one of my passions, right? We know that we're only identifying about 10% of women who carry hereditary cancer mutations. We're just doing a terrible job. And part of that, again, is not that doctors don't want to do it. It's A, they're not trained, and B, they don't have time. And it's this fragmentation of our healthcare. So you all need to be advocates for yourself when you're going to see your physician.
Yeah. All right, let's turn to evidence-based treatment options. Now that we've told you all the bad stuff, we're going to try to treat it. Let's talk about some of the options that are available. So we identified the categories of different treatments. We're going to dive a little bit into each one of those, but I'll let you both jump in here. Can you walk through some of the options that we have?
You start.
Okay. Well, I think about it in terms of the pharmacology bucket of things, right? And there's hormonal therapies and non-hormone therapies, and these are the ones that you need a prescription for. And then there are, we'll say, lifestyle modifications and over-the-counter or herbal things or mind-body therapies. So we'll put, some people will call them integrative health modalities or complementary alternative medicine modalities, and then we have our prescription bucket. Many of the prescription options are geared towards specific symptoms. So when we think about hormone therapy, there are systemic dose hormone therapies, meaning that it's hormone that is absorbed or distributed throughout your body. Specifically, most times we think about it in managing moderate to severe hot flashes and night sweats. I don't get to decide how severe or moderate they are. You get to decide that. Moderate to severe genital urinary symptoms. And so most times if those are in isolation, then we don't need to use systemic dose therapy. We can use local estrogen therapy in those areas that aren't systemically absorbed. So they don't often confer maybe the same potential risk that a systemic dose would be. Yesterday, we were talking, and Dr. Larkin shared a story that she had a patient that was told she couldn't be on her vaginal estrogen anymore because it was going to give her breast cancer. And that's absolutely not true. There's no reason that she couldn't be on that until she didn't care about a dry, itchy vagina anymore all her life, right? The non-hormone, and I guess with the hormone therapy again, for systemic dose, it could be prevention of osteoporosis, as well as we want to manage patients that go into earlier premature menopause until they would have at least reached the time of natural menopause. For the other options for managing hot flashes and night sweats in the non-hormone category, there's certain antidepressants that have been shown to have good efficacy and safety. Often these don't work as well as our hormone therapy option does, but for the most case, there's somewhere between maybe a 40 to 70, 40 to 65% chance, or reduction, I should say, in symptoms. But certain antidepressants, one of which is FDA approved with that indication. Another medication is gabapentin or pregabalin. Those are neurologic medications that sometimes are used for chronic pain syndromes, but again, they can help with hot flashes and mitigating hot flashes and night sweats. There's a new medication that was just approved almost actually a year ago. That's not only a new drug, but a new class of drugs, which is really exciting. In the past, we had always blamed hot flashes and night sweats on the decrease in estrogen. Our ovaries aren't making estrogen anymore, and somehow that is disrupting our body's ability to regulate our temperature. And so now we've got this exciting new research that shows that when that estrogen level drops, our brain sends a signal to release these other neurotransmitters. And with the release of those, they seem to have more of an impact, or maybe equal impact, on our thermoregulatory center. And so this new drug blocks the release of those other neurotransmitters and helps to minimize hot flashes and night sweats. Clonidine is a blood pressure medication. Some people say I don't want to not mention it because you might think I'm not smart if you saw it on when you Google search. It doesn't work so well and has some side effects, so not many people use it for that indication. And then the last one I'll mention is oxybutynin, which is a medicine that is used to treat overactive bladder syndrome. It also has some benefit to minimizing hot flashes and night sweats too. And I'll let you talk about all the other options.
Yeah, so I would tell you that, as Dr. Christmas said, menopausal hormone therapy, we know since 2002, we're not using enough. There's a tremendous need to improve number of women who would benefit from that, right? So in the studies, and I know we're doing a whole segment next, right? Recently, more additional data, again, coming out from the WHI, just really looking at risk versus benefit, particularly in those women close to menopause, 50 to 59, that really the vast majority of women get benefit, not risk. And, again, we should be talking to women and more appropriately educating them, because a lot of women, they've seen a doctor who's told them that hormone therapy is bad, which we'll get to, but then they self-minimize. Like, women will suffer a long time before they actually get to treatment, right? And they have unsubstantiated fears about the options that we have, including hormone therapy. What I see a lot of is, my internal medicine colleagues are using antidepressants first line. And as you heard from Dr. Christmas, right, they don't work as well. Hormones work much better for managing symptoms, and the antidepressants have a lot of side effects for women often who are already having sexual dysfunction because they're transitioning. So they're not as effective. And they certainly help with some of the symptoms, but again, I think for a lot of women, the conversation should be, if you're really symptomatic, hormone therapy may be the better option for you, and we have to kind of take away this overwhelming fear of the breast cancer, which we do have to talk about. But now, the other thing that my internal medicine colleagues are doing is telling women that it's natural and they just should go out and get supplements. So just last year, the Menopause Society did a really comprehensive review of the non-hormonal options that Dr. Christmas just talked about, and included in there were a lot of the supplements to review kind of what the data was. And my bias really is, in general, I'm not a supplement pusher in my practice. I say pusher, I don't mean that to sound so negative, right? I refer a lot to my integrative medicine and my functional medicine colleagues when patients have a desire to try to use supplements, because that's not my area of expertise. But in looking at the data that the Menopause Society did, there's just not a lot of randomized trials for these things, right? The data is not great. So the end conclusion of the Menopause Society was they really couldn't recommend a lot of these supplements. Where I have a big concern, and I talk about this a lot, is that their formulations are not regulated very well. So there are a lot of things, when you look at bottles, it'll say proprietary blend. These are mixtures of things. You don't really know what's in them. The dosing isn't regulated batch to batch. There can be variability. The FDA doesn't regulate these things the same way. In the vast majority of women who are young and healthy, I don't think these are harmful most of the time, right? I say, yeah, you're spending $800 a month to make your urine expensive, but not doing very much. But where I have an issue is in women who have other medical problems, particularly my breast cancer survivors who are on other medications. These things have just not been studied with drug-drug interactions, and so I'm really cautious in those patients. And my take-home is, if you're a healthy 50-year-old and you want to try these supplements, I don't think they work. Believe me, I've tried every single one on the market. I don't think they work well, and the data does not support that there's enough study of them. But again, in breast cancer survivors, people with other issues, I'm much more reluctant to recommend them.
You know, I know we're going to talk more about symptoms within the other panels, but I want to circle back to something that that you brushed on and we talked about. We've talked about everybody comes to this, you know, individually. Everybody has different symptoms based on age, also based on race and ethnicity. And I want to address that because there was a SWAN study too that I think that we should talk about and explain, you know, and where it brings us today and what we know and what we don't know.
So SWAN is the study of women's health across the nation, and Chicago happens to be one of the intake sites, but it was the first of its kind longitudinal study looking at women as we progress through this aging process. I think initially the cross-section was 1997, so it's been going on for a long time. We're still using this data. There's still patients that are still enrolled in the study are being evaluated, but there were over 3,300 women that have been followed. We took women from 7 different geographic areas through the United States and had different ethnic groups that were followed. So there's a white cohort, there's an African American cohort, Hispanic, Chinese, Japanese, and looked at really every aspect of menopause. These women were very courageous for volunteering to do this, but they had lab work done. They fill out more questionnaires that I could even think. So there's a lot of robust data, ton of information that's come from SWAN, that's still coming from SWAN. But one of the big things that they found was that there's some variation in how women experience menopausal symptoms, especially those vasomotor symptoms, the hot flashes and night sweats. And Black women like myself, we tend to have them for a longer duration of time. Our symptoms tend to be more frequent, more severe, and more bothersome too, for whatever reason. I tend to be someone, when I get a hot flash, not only does it make my heart race too, but I start to feel really dizzy. To the point where I might pass out. And sometimes in the operating room, I like it to be ice cold. And sometimes for the patient's benefit, it can't be ice cold. And my anesthesia colleagues are like, dude, we got to crank the temperature up. I'm sorry. As soon as they start cranking the temperature up, my temperature starts cranking up. And I start to get those feelings that are bothersome. Plus, I'm drenched when I take everything off. And if I have a meeting later, I don't want to go back in with an afro. So what I have them do is tape ice to the back of my neck and my lower back, ice packs. There's literally tape they tape around my neck. And my chairman came in, who's this very serious German man, and he's like, what are they doing to you? It's like, dude, mind your business. I'm having a hot flash. What are you here for? No one called you. So, some newer data, too, that's showing that Native American women also have more severe, longer hot flashes and night sweats, too. Lots of other things have come from SWAN, but that's one of the big things is variation and degree of symptom bother. Now, that still does not mean that every Black woman has hot flashes or night sweats. So that's not the takeaway for us here, too, or even from my colleagues. So I have plenty of patients that are like, yeah, never had those, Dr. Christmas. That sucks for you. Okay.
One of the things I would just follow up with about the hot flashes is, the other thing I hear from my internal medicine colleagues who are taking care of women and telling them just to take supplements and that it'll pass, right, is that this is just a lifestyle thing, right, which is like, it's just a hot flash. Well, I want to tell you, My sweet husband would tell you, I mean, he has seen me suffer through these and would say, oh my God, if men ever went through this, like we would have a cure for this already. Like this is like no idea. And when my hot flashes are bad, I disrupt my husband's sleep, right? I mean, I'm having drenching sweats at night. But the point I want to make is they're more than lifestyle, right? Thanks to a lot of good research that's been done by one of our colleagues, Rebecca Thurston. Hot flashes suggest that there's something different about women that are having severe hot flashes in terms of, we call it autonomic dysregulation, right? Their vasculature is not responding exactly the same way. And we know now that there's differences in cardiovascular risk with women who have more severe hot flashes. So again, like we're learning a lot of this data and we're starting to understand it, but the important takeaway is like we should not minimize these symptoms for women, right? We need to empower women to say, look, these are not only real, it is more than lifestyle. I have executives who come to see me. I had one recently who said, I sit in a boardroom and I suddenly sweat, it's uncontrollable, and my hair gets wet, and I'm in a boardroom with all of these men, and they're looking at me like there's something like crazy, like you have to do something for me, right? So it's more than lifestyle, because again, it is another marker that we need to think about and be very careful with women about what is future risk, what is cardiovascular risk, what is dementia risk, we really need to assess this in the context of this subgroup of women who are really having these severe vasomotor symptoms and really stop these other doctors. We need to educate them. My whole thing now is we need to educate doctors about this information because they need to stop messaging the wrong thing to women because this is really an important time.
Which is where I think that women have to become their own advocate, and I hate to say that because it puts the onus on them, but at the end of the day, to know what's going on, to have the tips, the guidelines, the symptoms, understand what's happening, so you can go in there armed and not accept those kind of answers. Okay, so guess what? It's time for some Q&A. You guys ready? Yeah? Okay. I think we're just going to do it by raise of hand, and Donna's going to bring a mic around. Just remember, please refrain from personal medical questions.
And also, if you can try to keep it to the topic, just sort of perimenopause, menopause, and beyond, that would be great. We're going to be doing a panel on hormone therapy where questions will get answered. We're going to do a panel on GSM, the genitourinary symptoms, and we're going to do a panel on mood. So if there's more specific questions to those, you can keep them. Actually, the hormone therapy, we're not actually going to have a Q&A, I don't think. But we will have a follow-up Q&A. So I'm going to get to who raised their hand. Someone here? And if you could also just keep it kind of short, the question.
Hello, I'm Dr. App, and a somewhat recent menopause certified provider, and I appreciate all of the work that you all are doing to support menopause treatment and education. Fighting the good fight. What about those patients that come in with all the pellets and all the I practice evidence-based medicine, and I know we're not supposed to do them, and I'm not doing them, but how do you convince them not to, as well as how to convince them that they don't need their labs checked?
I'm happy to start and you fill in. So this has become a big segment of my practice, right? Which is women who've been doing pellets for a while now come in and they recognize, they're spending a lot of money and they're starting to see stuff on social media or whatever. They may not be feeling so well with pellets. They're starting to have their side effects and they want to get off of pellets, right? And I'm really not a supporter of pellets. I have seen crazy physiologic or crazy levels in women with pellets. So the people who are doing the pellets, the vast majority of them are checking levels at the nadir right before the patient gets the next pellet as a way to reassure the woman that they're not getting super physiologic levels. I've had crazy levels that when I draw, because I try to convince them that they are having super physiologic levels, particularly of testosterone, because they're having the effects of testosterone, which is why they're in my office now. And I can examine a patient and see who's been on pellets for a long time with this super physiologic dosing. I also happen to have a transgender stepson who's on testosterone who wants those androgenic effects. And so you have to talk, I talk to patients and I say, like, these are the same hormones, right? And, the dosing really matters. And we need to really make sure that women understand that compounded and these dosing of pellets it's not the same as FDA-approved options. We have, if the term bioidentical is not the same as compounded pellets, we have to go back and really educate that bioidentical forms of hormones, there are FDA-approved options, and we can do them in a physiologic dosing range that's really appropriate. What I like to say, though, is that the reason, in my opinion, that pellets are such a rage still is because the first time a woman gets a pellet, particularly with the testosterone, they get very high-dose testosterone, and they are euphoric. Their hot flashes stop, their libido is tremendous, they lose a little bit of fat and gain a little bit of muscle mass, they notice body changes very quickly. That first pellet is a game changer for a lot of women, and they run around and tell 1,000 of their friends that they should get a pellet because they feel so well. But if you talk to women, and what we have started to learn and understand is that, so the brain in a woman who's never seen that high-dose testosterone before, that's part of the euphoria, right? And they tachyphylax to that over time, meaning that the brain suddenly starts to get used to that high dose of testosterone, and they don't have, with subsequent pellets, women do not feel as well as they used to. So they keep getting the dose increased, or the frequency changes, or they're going back. I've seen crazy things in my community of what kind of adjustments are made to women when they're doing this, but they generally don't feel as well. They don't have that euphoria anymore. And actually what starts to happen is they actually start to gain weight, and then they start to have some of the androgenic effects. And so, I mean, in patients who are coming in and haven't been on pellets, I can really go through all of that and say, I can help you without using pellets. For the patients that come to see me who've been on pellets for a long time, they already know all these things, and they're anxious to get off. And I will tell you, it's a transition. Women, when they go off the pellets, do not feel well for several months. And it really is educating them that they should expect this. And I really work with them in terms of what we do to manage them for the 3 to 6 months, again, while the brain kind of reacclimates to kind of normal physiologic hormone levels. So.
Thank you. So,
real quick, I have lots of pellet stories too that are not particularly good, but I have a good friend who had pulmonary embolism, and that's normally a contraindication for hormone therapy. And she somebody gave her pellets, and she was like, "Oh my gosh, I feel great." And and now and put it on like her social media stuff too, that like everybody should do this. And I thought, not only should everybody not do this, but you shouldn't do this. You had a pulmonary embolism. Please tell me you're still on anticoagulation right now, which she wasn't. And it became a big thing. I was like, you need to go into your internist now, let them know what you did, because once you get a pellet, we can't take it back. It's in your system. Sorry, I will let you take the next question.
Can the panelists, when we ask questions, just repeat the question? Because
Oh,
we're
I'm
actually
so
live
sorry.
streaming. Oh, no, we failed to tell you. We're actually live streaming, so for our audience not in the room with us. So we know that everyone has a ton of questions.
Sorry.
And just to know that we do also have a hormone therapy panel, and also just in terms of testosterone pellets, just can you explain that just a tiny bit? Because I think we didn't get to that. Like, what are they?
Oh. Well, so no, these are, women who are having menopausal symptoms who, again, largely, I mean, I feel bad for women. I know why they end up in these hormone centers. I know why they get these pellets is because we failed them, frankly. I mean, there just aren't enough of us that are knowledgeable, and women are falling through the cracks, right? So they find places to go. And, depending on the setting, women are really, unfortunately, misinformed about what they're about to have inserted into their body, right? It's told that it's bioidentical and safer. And again, this patient who had a prior pulmonary embolus, what I see all the time is that they don't often get a physical exam, they don't have a good medical history taken, and when they have complications from their pellets, bleeding, for example, the hormone center isn't managing that at all. They get sent to me. I mean, I can't tell you the number of times I get a patient who comes in who's been getting these pellets who now is bleeding, and the hormone center said, oh, we don't manage that. Like, I'm not sure how you can be prescribing medications and putting pellets in, if you're not managing the complications of that, I have a real issue. But long answer to just say, testosterone pellets are a way, women are symptomatic. They are noticing a decrease in libido. They're having hot flashes. And so these pellets can be a mixture of estrogen and testosterone, or a lot of times just testosterone in younger perimenopausal women they're putting them in, which gives very high physiologic or supraphysiologic doses of pellets. And these pellets last for typically 12 weeks. Women are getting them about every 3 months. It's a procedure to put them in their buttock, and it's out of pocket and cash, not covered by insurance. And again.
Okay.
Katie, are you?
How about right here? Oh, you go. Okay.
First of all, thank you for being here, and for the organizers and everybody here. What an incredible resource you're providing for women today. So thank you. I was really surprised to hear you both say that blood tests are kind of inconsequential for deciding hormone treatment. And so I guess my question is, what's your general advice? I live in Indianapolis, and there are some providers starting to see women in this arena, but
Yes.
good luck getting into them because there are so few. And so do you have general advice, particularly if you live in an area where there aren't enough of these providers, or language for talking with the providers that you do have to start this conversation? And what are you asking for? What should you ask for?
So I think the first part of it is really just to be organized when you're going in to see the provider, because at best, if you're a new patient, they might have 30 minutes to see you, right? If you're a return patient, it's probably 15 minutes. And so be kind to your providers when they run late, okay? Because that's really
what we're talking about yesterday.
Yeah, I mean, really, because that's, and it's not because we are greedy and want to make more money. My salary is the same no matter, I run late all the time, but it's because I wasn't a good steward of my, of my business, and I work for a major university that tells me how many people I have to see to be productive. So that's the first part. So when you go in, you actually really need to know what you want to talk about. You need to know what your symptoms are. You can write them all down so that you can come clearly and succinctly state them. Annual visit is not a problem visit. So when you make an annual appointment to see your provider, that's really, I'm doing a pap smear for you, I'm doing your breast exam, maybe ordering your mammogram, your colonoscopy, whatever, bone density scan, you don't really have any issues. As soon as you start talking about problems, that's a problem visit. Now, some of us are really nice because we know it was hard to get in, so we'll answer those questions, but it'll be fast. So the best thing you do is when you're scheduling the appointment, saying what you're coming in for. When you get there, having all the things written down, knowing what you've already tried that didn't work, right? Being very well aware of what your past medical history is. You can't assume they should know it because it's all in there. It probably is all in there, but sometimes we don't have time to go through every provider's note that you've seen, right? And if there's been a change from the previous year, either in yourself or in your family, that's important. So in those first few minutes of that encounter, you need to be able to be very clear. This is what's going on. I'm having hot flashes and night sweats that are happening multiple times a day throughout the night. I'm not sleeping well. I can't function this way. I need to know what my options are. And I've thought about hormone therapy or whatever, right? And I think that's how you lead the conversation to help direct it. Because oftentimes when you've come in clearly like that, even if the person says, you know what, and I'm not bashing because I think there are many wonderful family practice doctors, but maybe I'm family practice, I don't really do that. I'm going to send you to one of my colleagues that does specialize in that. They're more willing to help get you to the place that you need to be, even if it's not their area of expertise. In terms of the hormone levels, is that, if you think about it this way, I tell people 50% of us, if we're lucky to live long enough, are going to go through menopause. And everybody that goes through menopause is going to have zero estrogen, progesterone, whatever, right? But not everybody has symptoms, right? So even when I'm managing your symptoms, I'm just trying to help improve them, right? And it doesn't matter what that level is because I'm not treating to a certain level. And I think when we start to get into this concept of wanting numbers of our head is that, we're trying to figure out, well, what do I need to do? Where do I need to be perfect, where I don't have any aging symptoms happening? And that's again, like I said, I don't have the magic antidote to aging. None of us do.
But I'll follow up on a couple specific things. So in my younger generation now, right? I'm old, been doing this a long time. You know, data, my patients want data. I mean, it's amazing what's out there now. So I have my non-diabetic patients doing continuous glucose monitors. Everybody's doing their body composition and tracking that, and you know, tracking calories, and it's fascinating. And so that I understand where this desire to have more information about where you are in the menopause transition and these blood tests, and you know, now there's over-the-counter testing that you can get too. So the truth is, I don't mind if you do that test and you spend your money on that. Like, you know, if you go pick that up at Walgreens and you want to do that, that's okay. What I would tell you though is I don't need that to decide how to take care of you, right? You can tell me, I know, I trust you that you're having symptoms that are perimenopausal, and I can define that. And my management of you is not going to change based on what information you've just brought me into the office. The second thing I would just say is, again, be empowered. So I think there's tremendous resources out there. Let's Talk Menopause, the Menopause Society, lots of our social media, podcasters, physician influencers. There's lots of information out there now that's good information. And if you use those resources and have a sense of what you're thinking, again, it's hard to sort out. Patients tell me all the time they've been watching this stuff. They still can't really understand if they're a candidate for hormones or they should take hormones. But having a framework of going in helps when you can, again, be very focused with what you need with your physician. And then finally, if you get the answer from the physician, which too many women are still getting, which is, it's normal. Oh, I had a patient come in who saw her internist who came to me and said, he told me that their entire practice was a hormone-free practice. What does that mean? Like it's a statin-free practice, it's a thyroid-free practice? Like what does that mean? Like that's the level of lack of information that's out there. So if you have that experience, I would just encourage you, again, there's resources for finding a provider from the Menopause Society. There's lots of great telemedicine programs that are happening now if resources are bad in your community that you can try. So there's lots going on, but you have to advocate for yourself.
And I would also say, just on that note, the QR code up there on your screen, you can check out the Let's Talk Menopause Guide resources, including tips for finding a menopause practitioner and getting care, and those are really great guides. So the QR code is going to be up throughout the day. Okay, we have a few minutes left of this panel. I have one up here at the front too, Donna. Can I? Yeah, because she was waiting. Can we?
I don't know. There you go.
Thank you for all of your information. I guess what I'm about to say might be, I don't mean it to be harsh, but we focused an awful lot on, sorry, I don't know how to use a microphone, on hot flashes. That was not my experience. I have an autoimmune disorder. I have sexual dysfunction. No doctor talks to me about that. Nobody talked to me about all the other types of side effects. And I guess it's frustrating because we're still focusing on this one symptom that not everybody has. It took me a long time to find a doctor. She happens to be here today, Dr. Rahman, who knew how to help me. Sorry, I'm emotional. It was a lot. It was a long journey. Anyway, I'm done.
And I apologize that you feel that way. I think one of the reasons is because we have a whole segment at the end about that. And I would just say, I mean, I hope that we gave you the impression that there's a spectrum of symptoms. And absolutely, I mean, again, I'm sorry that you've had that experience. And I'm sure you worked very hard to advocate for yourself to get where you are. I mean, I can tell you that all of us in practice, we do talk a lot about sexual function with that. And I think we didn't focus on that right now because of the nature of this portion of the panel. But
we're gonna have a whole panel at the end for that,
I
30
hear
minutes,
you.
an hour.
And again, I mean, this is about trust women. Women, if you talk to women, I mean, I'm the internist. I take the history. I mean, I tell the medical students, right? Like, you can get everything from a history if you actually spend the time actually talking to the patient. They'll tell you what you need to know. And like, that's, again, we need to have time to listen and to hear you, and you need to advocate for yourself, and which you did, obviously. But it is a huge mess, and I'm sorry you had that experience.
Okay, Donna.
First, I do want to thank you guys for being here, because it's very nice to know, like, struggling, that there are women like you that advocate for women struggling like us. and I really appreciate that more than I can say. I did want to know one of the biggest markers of perimenopause for me was panic attacks. And I feel like that's not often discussed, and I had to go through hurdles to find out where mine were coming from. And I was kind of wondering if those also come from the same type of hormone imbalance that causes things like heart palpitations.
So I can tell you I see that in practice all the time, right? Women who have never had mood disturbance before, I have a patient who I have, again, I'm old, I've been taking care of patients for a long time. She's been my patient for 20 years, never had any issues like this, who literally called me from the side of the road, pulled over with a panic attack saying, I don't know what's happening to me. I just called my husband to come pick me up. I can't drive. Like I'm a crazy person. Like there's something wrong. And it really was completely hormonally driven. And I know we're going to do a whole section coming up. But again, it's that period of time when it is a window of vulnerability where the hormone changes that you're having, it's not the absolute level. This goes back to, again, why we don't need to measure actual levels. Because again, I don't need a level to tell you what's happening to you. You're telling me what's happening to you. And it is related to these huge swings that you're having. Many times in the perimenopause, hormone levels are actually higher than they were during the peak reproductive years of the 20s and 30s, right? And then they drop very abruptly, which is why migraines are often much worse in the perimenopause. But the mood disturbance you're describing is 100% related, and we'll hear more about that. It's really a common thing that I see. And again, it's the common thing where my colleagues, because they don't know the data and they don't do this and they don't think about it through a lens of, my gosh, my patient actually is perimenopausal and having these hormonal things. Maybe I need to think about that as contributing to it, as opposed to just saying, you're under too much stress and you need to exercise more and here's an antidepressant. But your experience I see in practice commonly.
And those things do help too, though. But when we say
Yes,
many,
yes.
40% of women will experience mood changes or even anxiety, as you described. And if you have a history of having depression or anxiety, even if it was postpartum depression, and let's say you've been stable for many, many years, you're at a higher risk of recurrence or around that perimenopausal time frame. And it's amazing to me sometimes that even when I just explain that, people will take a sigh of relief and say, okay. And then many of them don't, when I start to delve into what we can do to help and give treatment, they're like, no, I actually don't think I need anything. I just needed to know that this was normal, that there wasn't something wrong. So.
And I will just follow up, just to say that in the perimenopause, one of the things that often works very well and is helpful is continuous oral contraceptives, right? So what the continuous oral contraceptives do is quiet ovarian production of hormones, which is all over the map, right? And then we're giving you even doses of hormones back. And it can be very helpful for the mood as well. So there's lots of different treatment approaches, but again, back to Dr. Christmas's point, I agree. I think sometimes just women understanding that this is real, there's real physiology behind this, is really empowering to say, I am not crazy, and this is like a time of life, this is bumpy, this is hard. Like, it gets better on the other side for many women, but like, it's real what you're having, and we should address it.
Well, I know we didn't get all the questions answered. We are going to have an opportunity to ask them during the other panels, so please make note of that. And also, there's going to be a menopause talk in June focused on answering just questions that did not get answered today. So thank you both so much.
All right.
Thank you.
Thank you.
Our next panel, I'm excited about the facts of menopause hormone therapy with Dr. Sharon Malone and Dr. Mary Claire Haver. And we'll bring them on up. Dr. Mary Claire Haver is an OB/GYN and certified culinary medicine specialist in 2021. Dr. Haver left traditional medicine and opened Mary Claire Wellness, which cares for the menopausal patient. And she just published her second book, The New Menopause, this week, as a matter of fact. Dr. Sharon Malone is the Chief Medical Advisor to Alloy Women's Health, a digital health platform for perimenopause and menopause treatments. Before that, Dr. Malone was an OB/GYN in Washington, D.C. for over 30 years. She is the author of the New York Times bestseller, Grown Woman Talk, which came out just a few weeks ago. All right, I'll let you take it away.
Okay, thank you all for coming out. I just love this, and nothing makes me happier than having a conversation with my friend, Dr. Mary Claire Haver. We are out here, and we've been doing this for quite a while, have we not? And we really want to have this conversation to make sure that women understand what's available. And our topic today is really the facts about menopausal hormone therapy. And I think the first place to start is really at the beginning. What is menopausal hormone therapy? It has a lot of names. It is now menopausal hormone therapy. It used to be known as hormone replacement therapy because I've been around long enough that that's what we called it back in the day. It's also called estrogen therapy. It's estrogen progestin therapy. These are all names for the same thing. And basically, it's using hormones to treat a hormonal problem. And now, as we have more options, testosterone may even be part of the menopausal hormone therapy. So, as we're talking about this, just know that we're talking about general class and that we're using hormones to treat the hormonal transition. It doesn't always start in menopause. We actually can start treating these symptoms because we know that they may occur 4 to 10 years before you actually get to the last period. And so depending where you are in the spectrum, as Dr. Larkin said, sometimes we use birth control pills, which are hormones, by the way, for people who are afraid of hormones, but they've been taking birth control pills for 25 years.
Or vice versa. Like
Yeah.
birth control's getting a bad rap on social media.
Which that's a whole other conversation about why that is the case. But nonetheless, just know that when we're talking about class of medications, hormones used to treat hormonal issues.
So when we talk about menopause hormone therapy, we have systemic therapy, and I'm losing my voice. I've been on a book tour, so sorry. And then we have local therapy under the big umbrella. So for systemic therapy, it's something either goes through the skin or we take orally or goes through the mucosa, and it treats everything. It goes into the bloodstream and it hits every organ's system in our body: brain, bones, heart, lungs, kidneys, everywhere, genitourinary system, etc. Local therapy is usually topical. Okay, we're using it locally, generally in the genitourinary area, sometimes on the skin. It's a little controversial, but so in the systemic category, we usually start with estrogen. When we're talking about menopause hormone replacement therapy, estrogen is kind of the mainstay of what we're talking about. And then if you have a uterus, progesterone is mandatory to protect the lining of the uterus from developing endometrial cancer from unopposed estrogen. Okay? If you don't have a uterus, or you have a progestin-containing IUD, or you were born with, you had a hysterectomy, whatever, progesterone is optional. And for some patients, adding in progesterone may be a little more helpful for sleep or some of the nighttime racing thoughts and anxiety, though it's not FDA approved for that. If you don't have a uterus or have that progesterone IUD, estrogen only is generally where we start with patients for menopause hormone therapy. So when we talk about estrogens, so we have estrogens, we have androgens, and we have progestogens when we talk about chemical formulations. Lots of terms out there that you'll see in layman's social media and news reports about bioidentical and synthetic and all these different things. Bioidentical, or in the UK, body identical, just means it's chemically similar to what our bodies make. So our ovaries make estradiol by and large. They make several smaller estrogens, but they're not really clinically that relevant as far as we know. Estradiol is the main one. That's the powerhouse. That's the one that is through our reproductive years. Estrone, you'll hear about. That is what is created in the periphery, usually in fat cells from peripheral conversion from androgenic precursors. That is the dominant estrogen in a postmenopausal woman because our ovaries have stopped making the estradiol. Estriol, which is in some formulations, is what our placentas make if you've ever been pregnant. Okay, but it is formulated and is occasionally used in different formulations. But by and large, those of us who do routine menopause care use estradiol for menopause hormone therapy. Sorry, I'm trying. I'm joking. So for the progestogens, we have progesterone, which is the body identical one. That's what our ovaries make. And then we have progestins. Again, a lot of controversy and a lot of misinformation about synthetic versus natural. Progesterone molecule is humongous, okay? And it doesn't pass through the skin very well. So if any of you have been given a progesterone cream with your estrogen in whatever form, talk to your clinician, because probably you're not covered. More than likely, this is not enough. You're not getting enough penetration through the skin to protect the lining of that uterus. Okay, so I'm really hesitant. I've never prescribed progesterone creams for anyone. The progestin, like in the Combi patch, it works great. Okay. For my patients, I typically, when I'm going to give a progesterone, it's going to be the oral micronized progesterone. The testosterone, another tricky business because we don't have an FDA-approved option for women. So that's the main androgen. You don't want to do an oral form. It can be hepatotoxic. There's a lot of issues. Unless it's undecanoate, that one's actually safe. It's not available in the U.S., mostly, I think, in Australia. So, so if you're going to do a testosterone option, you want to do a non-oral option like the cream. So FDA has the male-approved versions of like T-Stem, the gel. If you're lucky enough in your state that you can get a pharmacist to prescribe it to you, that's typically what we try to do. I live in Texas, and there's no one that likes to get more involved in a woman's health care more than a Texas state senator is a Texas state pharmacist. So I've had patients who were slut-shamed, and accused of transitioning when they tried to pick up their T-Stem gel. It's horrible. And so for a lot of us, we kind of are left with the, not our favorite option, but to compound something. Because when something's compounded versus FDA approved, I love compounding, I love having options, but we really try to stick to FDA approved options because they're tested, they're clinically tried. There's a 98% chance of what they say is in that box or that jar is in there. The compounders are just making it up batch by batch. No one's really running behind them to do a lot of testing, okay? So that's really the overview of systemic versus local.
And can I say this, because I think this is really important, because there's a lot of confusing terminology. Someone says, I want natural, I want synthetic, I want bioidentical. And this is, I think, a really important point for you to know. The only natural estrogen is Premarin, and natural means it exists in nature. Now, it happens to come from pregnant mare's urine, but that's natural. Everything else is synthetic. Synthetic simply means it is taken on a pejorative term, but synthetic just means that it is man-made. So even the estradiol, which is bioidentical, which is the same hormone that we make, if you drew it on a chalkboard, it would have the same chemical structure, it's made. Same thing is true with progesterones, or the progestogens. You can have, when we talk about synthetics, we're usually talking about the non-bioidentical progestins that are used in birth control pills and some menopausal hormone therapies. However, even the bioidentical progesterone is synthetic. So I don't want you to get the terminology confused, because it is sometimes very confusing, and that we like terms like, but I want natural, I want organic, I want, and this is something that I do say from time to time. I said, well, you know what really is organic? Bullshit. Very, very organic. So sometimes all I say is just be aware, and that when you're looking at terms, what does it really mean in terms of the effectiveness? So this conversation is really about estrogen, progestin. Let's not get caught up in the terms right now, because they're both, all of them are bioactive, which is what we're trying to use to treat.
So when we talk about a birth control pill or birth control patch or ring, when we talk about contraception, hormonal contraception versus menopause hormone therapy, the biggest difference is dose. Contraception was developed, hormonal contraception was developed to stop ovulation, so no egg, no baby, okay? It happens to treat a whole lot of other stuff, menorrhagia, acne, dysmenorrhea. We use it for heavy bleeding, cramps, all those things, okay? When we stop ovulation, those things get better. Menopause hormone therapy was developed to stop hot flashes, and you need much less than what is required to stop ovulation. So I have to talk patients off the ledge when I suggest using a birth control pill for their perimenopause, especially if they're having dysmenorrhea or acne or whatever else on top of all of their perimenopausal symptoms. Like, oh, I don't want birth control. I'm like, it's just a little higher dose. I mean, the difference between a low dose birth control than low estrogen and the higher dose menopause hormone therapy is very small. And so, these are tools in our toolbox to help you. And, not to be suspicious because of something you read or, and remember, a lot of these terms are marketing terms, not medical terms. I would never pick up the phone and call Sharon Malone and say that, I'm going to give someone bioidentical whatever, or she has, what's my other favorite one? She has estrogen dominance.
Oh, yeah, estrogen dominance. Yeah, there's a lot. But and the one thing, before we leave the systemic conversation, I really want to say that systemic hormones can exist orally or transdermally, and that transdermal just means that's pills, that's patches, sprays that go through the skin. There's even a ring that you can use that's taken through the vagina. That is a hormone therapy replacement level, but we don't use that very much, but it is available. And then oral just means it just goes through, you take it as a pill, goes through the liver. And then all of the local hormones that we use are, by definition, transdermal because they're used typically vaginally.
They're transmucosal, yeah. Okay, I think next slide. So when we talk about the potential symptoms that these medications can be helpful for, and this goes along with the last talk, we know we have the things that the FDA has, we've done tests, it's proven, and that's going to be your vasomotor symptoms, so your hot flashes, your night sweats, and they're trying to include palpitations in that, which we now think is a vasomotor symptom, though not FDA approved for that. Prevention of prevention of osteoporosis? Mm-hmm. Yeah, and but also it's great for the 90% of us. The last study I read, 90% of us will have some form of dysfunctional uterine bleeding during our perimenopause. These medications can be great for that. Who had the crime scene periods during perimenopause, and we're rushed to surgical options instead of hormone therapy that probably, at least a trial to see if it could take care of the bleeding and all the symptoms that you were having.
Yes, and the number one reason why perimenopausal women come in to see their gynecologist is usually because of the bleeding. They don't even, because you're not even thinking about some of this being menopausal symptoms, but the amount of bleeding, and it really breaks my heart, what we normalize as women. We have gotten to the point where we have just normalized the language of suffering because we think that's as women, that's what we do. We suffer through cramps. We suffer with migraines. We suffer through the heartbreak of psoriasis. And we just feel like that's normal. But because we don't talk amongst ourselves, normal is what's normal for you. So if you've been having 7 to 10 day periods, you just figure, well, that's normal. It's not. And if you are having periods during this perimenopausal transition that make you never be able to be more than 5 minutes away from a bathroom, or you are wearing adult incontinence products to control your bleeding, that is not normal. And so this is the conversation that we really want women to understand, that from perimenopause into menopause, and we sort of know those, the symptoms, the hot flashes, and thank goodness Dr. Larkin said that. Hot flashes, let me just say this, are not benign. They're not funny. They're harbingers of sometimes of impending cardiac disease. When you have hot flashes, it disrupts your sleep. It worsens your brain fog. It makes you make bad dietary choices the next day. Lord knows that does. And you're certainly not feeling like exercising. So when we talk about all these potential symptoms, even though we talk about the hot flash a lot, just take note of what's here. And it helps you know when to access care. Don't normalize feeling bad, because Dr. Haver and I are really trying to change that narrative for women as we age. The expectation shouldn't be that getting old just means, oh, well, I'll feel bad. No. We're here to tell you that there are things that you can do and medications that you can access that will improve the quality of your life. And I think that's important, and that's something we've got to start choosing for ourselves.
Right. I love the last chapter of her book. Has anybody read Grown Woman Talk yet? Where you talk about becoming a benefactor and not a burden.
Yes.
This is a conversation I have with my patients. When we're mapping out her next 30 years. Typically, you know, my patients are multiple ages, but, you know, I'm 50, almost 56. And we're talking about what are your risk factors, like Dr. Larkin and Dr. Christmas talked about, you know, like how are we setting your path so that, I call it my nursing home prevention program, you know, like what are the tools in our toolbox? Menopause hormone therapy can be a huge part of this. Now we're going to talk a little bit about prevention. It takes a while for societies to catch up and guidelines, but the data on cardiovascular disease is clear. The benefits, you know, if you start hormone therapy within 50 to 59, you know, within 10 years of your menopause, you have a lower risk of cardiovascular disease, as much as 50% per year. And so it's very protective for that disease. So those are the conversations that we're having with patients. The acute stuff, the hot flashes, the things, the brain fog, yes. But then we're also trying to help her map out, could this be another tool that's going to help you be a benefactor and not a burden on your children?
And you know, the one thing that we really, as we're talking about it, I'm sure all of you are sitting out there going, well, my God, if it's that great, why aren't we all taking it? And yeah, isn't that a question? But we have to own why that is. And, you know, and without going into great depth, and we can, it started, for those of us, let me just say, I've been practicing, you know, I'm 65 years old, and so I practiced for 10 years before the Women's Health Initiative came out. And the conversation about hormones and hormone therapy and who we were prescribing for was very different than in the post-Women's Health Initiative era. So that notion that you have in your mind about hormone therapy being bad, hormone therapy causing cancer, hormone therapy not helping you, really came from that one pivotal study. And I remember that fateful day when the regulators at NIH held that press conference and said all these terrible things. Well, women flush their hormones down the toilet. And again, it's disadvantaged a generation of women in the 22 years since then who have grown up with the idea that hormones is bad. And we've also disadvantaged an entire generation of physicians who also think that that's bad. And that's been the conversation that, you know, that we're trying to have and trying to dig out of that hole. But the one thing I want to tell you about this is that, and I really have to give credit where credit is due, because I'm of the old group of people. And, you know, when that study came out, the reality is that many of us understood the flaws in the study in 2002. The problem was I'm trying to convince you in my office, and there are many, many researchers out there and doctors who complained mightily from the very beginning. Dr. Phil Sorrell, Dr. Avram Blooming, Roger Lobo,
Simon.
All of the, you know, who were saying, whoa, wait a minute. But we talked amongst ourselves, and that conversation sort of never made it out into the general sphere. And I say this a lot. I said, you know, you get indicted on page, you know, on the front page, and you are acquitted on B-17. Nobody saw that part. And so this conversation has been ongoing for years. So I don't want to give you the impression that we all of a sudden just learned something new about the interpretation of that data. It's always been problematic, and we have discussed it, and unfortunately, we were not able to communicate that to the public effectively. And that's why I said, let's give credit where credit is due to the people like Dr. Mary Claire Haver, who have been out there in social media. It has actually broadened that conversation, because I don't have to have it. I could have it one-on-one for, all day, every day, and still it would only be a drop in the bucket. But now I think that through understanding that there's a different way that we educate women, it's facilitated this conversation. This would have never happened 15 years ago without social media and getting women really activated about this issue.
And the Menopause Society, Lisa, Dr. Larkin, they are not part of American College of OB-GYN. They kind of this was kind of radical what they did, decided to make a clinical society, off the reservation. When we look at the American Board of OB-GYN, I get my board certification, many of us do every year. We go read a bunch of articles and whatever. There's no menopause category. There's gynecology and surgery and obstetrics and pediatrics and oncology and all the important things, very important stuff, right? There's no menopause section. It gets buried in office practice and geriatrics,
Right. Now, and we're going to get back to the issue at hand, but I think it's really important that you understand the context. How did we get here? Where did we start? What happened that changed everything overnight? And then how we are gradually trying to get back into getting women activated. And let me say this, because I think it's very important. We are not here to tell you what to do. I think that we are here to give you information such that you can advocate for yourself and access hormones and not allow doctors to tell you what you can and cannot have. Because understand this, a lot of times you're getting information from someone who does not know what they're talking about. And anytime someone says, well, my doctor said I can't have that, and I will say, you know what, perhaps you should have your doctor read the North American Menopause Society's 2022 guidelines, which have revised everything that we think about hormones. And a lot of the myths and things that we think the reasons why we take ourselves out of that conversation are not true. And this information is so vital because it is evidence-based. You don't have to say, this isn't Mary Claire Haver's opinion or my opinion. This is a consensus of experts who have said, all right, this is what the data is. Let's walk back some of the misconceptions that we've had about hormone therapy.
So, as most of you know, we're not educating our providers. That's a huge, in the new bill that's been put forth yesterday or day before with Halle Berry, it was in the news. I think 50 million of that is for education of clinicians because we have a huge gap. And, so that we can all bring each other. Right now, we're Band-Aiding. You can run over here to telemedicine or go over here to concierge practice or pray to the hell that your OB-GYN cares or has had enough time to read something, But I really don't think that this should be dumped on the lap of the poor, busy OB-GYN who's trying to deliver babies and do your pap smears and everything. This should be mandatory curriculum for every physician who touches a woman. I'm in my clinic, I'm part cardiologist, part rheumatologist, because those specialties are struggling to get up to speed on how these menopause and how women are different than men in medicine. I mean, it's part of that bigger picture that was talked about earlier.
Right. And this is something that I want you to understand. And I don't know, I will not be conspiratorial as I become conspiratorial. But I will say this, it is amazing to me that when it comes to issues around women's health, and particularly anything about women's health that involves our reproductive systems, everybody's got a say in that. As an OBGYN, I don't think I have ever once had a patient come to me who's getting their high blood pressure or their diabetes managed by their internal medicine doctor, and they come into my office and I'm like, oh, well, why are you taking that? Get off that. I don't believe in that. Who does that? Except when it comes to women and hormones care. No one owns it, but everybody wants to be in the conversation even when they don't know what they're talking about. So after all the time that we've spent sort of explaining to women, here are the risks, here are the benefits outweigh the risks if you fall within the parameters of who should take, and only to go to their doctors and their doctors will tell them, you gotta come off this. This is terrible, this is dangerous. I don't know what that's about, but I think that that is something that we have got to at least address within the medical profession ourselves, that we need to understand and respect our colleagues, because I don't think it's always a two-way street, particularly when it comes to OBGYNs and people who are trying to prescribe. I tell this story because it is true. I've been on hormone therapy for 15 years, you know, full disclosure. I made that decision for me. I didn't need anybody to tell me that, but I made an informed decision, and I will stay on it for as long as I want to be on it. But I went in to see a new internist, and she said to me, as we're going over medication, she said, and I told her I'd take hormones, she said, "You know I'm not a fan." and I was like, "Excuse me? You know what I do for a living, right?" But the point being, if this is what she's telling me, then I know what she's saying to people who don't know better. And so for all the good work that we're doing about trying to educate, it gets undone on the back end. So let's get back to one of the things that when we talk about hormones, we have to say, okay, well, who should take, who can take, and who shouldn't take? Because I think that's an important thing for you to understand, because I think that the misconceptions about who can't take are not as great as you think they are.
So if you have active breast cancer or any tumor that's being fed by one of the hormones, you're not a candidate. You know, you need to go through your treatment. You may never be a candidate, but you've got to get through your treatment for that. Breast and uterine are the two big ones. Not every gynecologic cancer is going to give you an increased risk of recurrence if you choose HRT after. There's a great article in the British Medical Journal about this. So a lot of misconceptions about that, but definitely, your breast and your uterine cancers. Unexplained vaginal bleeding, which 90% of us have, during perimenopause. So we're not going to rush to start hormone therapy. We need to get in to see the gynecologist, make sure that you've ruled out polyps or growths or possible endometrial cancer. So not a candidate until we get that figured out, all right? Severe liver disease, not mild fatty liver. I'm talking, active liver disease, liver cancer. We metabolize estrogens in our liver, and that process isn't going to work very well when our liver is diseased. So that's a really nuanced conversation, so not anything we'd rush into. And then history of blood clots and cardiovascular. If you have active cardiovascular disease, we don't want to put, estrogen is better at prevention than cure in cardiovascular disease as far as atherosclerotic disease. It's very protective of the intima, the lining of those arteries going around the heart and in the carotids, okay? However, once those diseases start or you develop plaques, calcified plaques especially, then you probably, we need to get some workup. So when my patients come in and they have a history, high risk for cardiac disease, we're getting a calcium cardiac score at the CT scan around the heart. We're getting a full cardiac workup before we even start the conversation.
And here's something that I think that is very important too, is that we never say never. Because there are certain circumstances that is really outlined nicely in the North American Menopause 2022 guidelines, even about certain cases with breast cancer. It depends. It depends on the stage of your breast cancer. It depends on whether or not you have completed your therapy, your treatment for your breast cancer. And it depends on what your ultimate goals are and what your expectations are. So it's not even a never, never on breast cancer, because there are people that have triple negative breast cancer. There are people that have breast cancers, they've completed treatment as young survivors of breast cancer, and they are now 10 years past with no evidence of recurrence. There may be circumstances of which that is appropriate. But again, that's a conversation that you have with your doctor on risk, benefits, and your treatment goals, not a no, never, dear. You do get to be involved in an informed way and to make the decision about whether or not you want to treat your symptoms, because for young women, that's a real problem. And that is, and there a lot of treatment is being withheld. Even local, just vaginal therapy is withheld from a lot of breast cancer survivors. And at a minimum, everybody can have vaginal estrogen. It's not enough to affect your outcome one way or the other.
And there's not a one-size-fits-all.
Right.
It's a lot of trial and error sometimes, especially in perimenopause. What works at the beginning of your perimenopause may not work at the end for your symptom control. So, it's so wonderful that we have options, not just the straight up estradiol, progesterone combos, that we have some of the SERMs, basidoxifene, that we have some Veoza and some of the other medications for patients who are not good candidates. So don't feel like, oh my God, I'm not a candidate and there's nothing that we can do for my menopause. Look, menopause care is more than hormone therapy. It is nutrition, exercise, stress reduction, sleep optimization, all of that. It's synergistic together.
Here's another big one I think that women take themselves out of the conversation, and they will say, well, I can't take hormones because I have a history of breast cancer in my family. Who doesn't? When you think about the fact that most women will have, we say, a population statistic of 1 in 8 women will have breast cancer at some point in their lives, but your biggest risk factor for having breast cancer is living long enough to get it. Age is the biggest risk factor, not whether you take hormones or not. As a matter of fact, the overwhelming majority of women who get breast cancer in this country do not take hormone therapy. And I think we should take a little bit of moment and do a happy dance. Even though the incidence of breast cancer is increasing, the mortality rate for breast cancer has dramatically decreased since the 1980s, since we were, and then we were saying, my God, the mortality, it was terrible. And I think that's what cemented breast cancer is bad and uncurable and you will die. It is those old statistics, not the current one with with early diagnosis and treatment. Now, we're about to run out of time. So I think we want to run through really quickly some of the myths that you talked, and I think we've talked about breast cancer. Again, it does not
Right. So a healthy breast
breast
cell, right? We all are born with healthy breast cells, and then some of us undergo malignant transformation due to a zillion different reasons, lifestyle, genetics, oncogenes, whatever. And so estrogen, if you retain an estrogen receptor through the malignant transformation, they can use that estrogen receptor to kill the breast cancer cell. And so that kind of in people's minds is like, oh, estrogen is bad, and that,
Right.
and so we have our highest levels of estrogen typically in pregnancy, and breast cancer is very, very rare, except for the poor patients who usually have a very, genetic, reason for them to get breast cancer so young.
And here's the thing that I think is really an important thing for you to know about the Women's Health Initiative. That same study that told you that estrogen was terrible and it was going to increase your risk of breast cancer. Let's put that in perspective, because 26% increase, and let's just take it at face value, and even there's some discussion about that. But let's take the Women's Health data as it was reported. A 26% increase in the risk of breast cancer. That sounds terrible, right? Oh, who wants that? But what did that actually mean in absolute numbers? That was only with women who took estrogen and progestin. And what they found for women who took estrogen and progestin, who took for more than 5 years, and that's when they stopped the study, they found that the annual incidence of breast cancer was 30 women per 10,000 women per year will be diagnosed with breast cancer. Why? Because you're a woman and you've got breasts. What did adding estrogen and progestin do to that risk? It went from 30 per 10,000 women per year to 38 per 10,000 women per year. Less than 8 per 10,000, or less than 1 in 1,000 additional cases of breast cancer in women who took estrogen and progestin. Well, less than 1 in 1,000 additional cases does not sound nearly as scary as a 26% increase. But here's the other bottom line, is that even if you take that number, the less than 1 in 1,000, there was no difference in the survival rate of women who took estrogen versus women who didn't take estrogen. So you were no more likely to die of your breast cancer on or off hormone therapy. That's number one. And the second part that I think was really, that just went over everyone's head, is that there was an arm of the study that just did estrogen only. That 5 year, we stopped at 5 years on the estrogen and progestin. The arm that for women who had had hysterectomies and took estrogen only went on for 2 years, and they did not see an increase in the risk of breast cancer. And now we have the luxury of having a 20-year look back on those women who took estrogen and progestin and the women who took estrogen. And guess what? They have found that in the 20-year look back, the women who took estrogen only had a 22% decrease in the incidence of breast cancer and a 40% decrease in the risk of dying from breast cancer. Now, did you hear that? You know, so you can't, we have to at least acknowledge that there's some nuance when it comes to estrogen and estrogen progestin. Is it the estrogen and progestin that's the problem? Is it not a problem? Clearly, the estrogen-only part of it does not implicate estrogen as the etiologic factor for why women get breast cancer. And I think that, you know, again, these are the kind of conversations that we need to have as physicians. There's more research that needs to be done into this.
This is such an important topic, and it deserves its own, you know,
Yeah.
so this fall, Dr. Lisa Larkin will be giving an entire presentation on breast cancer and hormone therapy.
Okay. All right, what are our other myths? Okay. Oh, this is yours.
See, number 2,
How
I
long?
should, if you're relative, we kind of covered that. It's too late for me to start menopause hormone therapy. That's a maybe. I mean, estrogen therapy will always protect your bones forever. You started at 90. It was, you know, protect your bones. You will lose the cardiovascular preventative benefits probably somewhere in that first 10 years. Doesn't mean you can't start it after 10 years. Again, I do a lot of testing, nuanced conversation, but if she's still symptomatic after 10 years or over 60 and she wants the other potential benefits, we talk about it. We try to do it safely and rule out other diseases that may, you know, that we don't want to put estrogen with. There's no age at which we have to stop hormone therapy. If you're enjoying those benefits, those can continue as long as for you the benefits outweigh the risk. Nuanced conversation with your healthcare provider.
And that is something that has changed because somewhere we sort of saying, you know, when we were having the conversations between estrogen and hormone therapy is bad or it's not so bad, we kind of split the baby and said, well, it's kind of bad, but only if you take it, you know, only if you take it more than a certain amount of time. And there was really no real evidence that said that looked at how long you should take hormone therapy. And yes, and that is one of the new things that there's no reason why if you go to the doctor, you're good, you're healthy, you're happy at 60 and they go, oh, time's up. Time to start feeling bad again and having those hot flashes. No reason for that.
A woman should never use hormone therapy exclusively for prevention. Well, that's what the U.S. Preventive Health Task Force says, but I have a lot to say about that. So there's what we call the healthy cell hypothesis or the timing hypothesis. Here's what we know. Women who go through menopause early have much higher risk of diseases for age-matched women who go through menopause later. It is the time away from estrogen that accelerates certain disease states. Insulin resistance, cholesterol levels, the risk for cardiovascular disease, abdominal fat deposition in the form of visceral fat. Those are non-negotiable, okay? That happens through the menopause transition untreated. So estrogen is better at keeping you on the normal aging path, like we age, you know, on that path that you were on pre-menopause. We're still aging. These things are still happening, and they're very interconnected, but we accelerate in several, you know, chronic disease states through the menopause transition. And what estrogen can do is slow that down as a menopausal person. And so these are the conversations that I'm having with my patients about potential, even though certain guidelines need to get their shit together and catch up.
And the one myth, I'm not feeling bad enough. I should wait until my symptoms are really bad before I
It's not an epidural.
Yeah, exactly. And look, exactly. And let me say that how bad is too bad? You know, I mean, I'm not into suffering. And I had done this long enough, and I believe women when they came in and they told me their symptoms. And when I got to the point where I was at, I'm like, no, I'm not going to sweat in the operating room. I am not going to be in the middle of my sentences. I'm giving a patient pre-op instructions and forget what I was talking about. Those are things that are important to me for my quality of life and my functioning. So no, but the time to start is when you say you're ready to start hormone therapy. We're not waiting for, oh, you only have 5 hot flashes, or you only woke up 2 times last night. You say, and only you know how you feel and when you are ready to access care. And that is, I think, a really important point for women to sort of, get activated and advocate for yourself on that front. Let's see, what we have, compounding. I think we sort of talked about bioidentical and all that. It's not, bioidentical and the ones that are compounded hormones, they are not safer. The only difference is that compounded hormones, because they are not FDA regulated, they do not come with the same warnings because they don't have to put it on the label. But that should not give you the impression that they are safer. It's what it is.
Do we have? All right, we have a couple minutes for questions. Somebody.
But we have, we know everyone has so many questions, and we want to hear from you guys. So what we did is we have an upcoming menopause talk with our Chief Medical Advisor, Dr. Robin Noble, who could not be here today. She is fabulous, just like these other women who are up here. And we're going to take your question, come to that menopause talk to ask your questions. We will take one question, and then I think we do have to go to break.
I feel like I won the lucky prize. I'm going to play the lotto today. First of all, thank you both so much for your books. I cannot read fast enough, so I haven't finished them both yet, but they're literally in my hotel room. Question of something that I heard a lot and a lot of women hear. We also get diagnosed with IBS a lot. So many women get diagnosed with bowel symptoms and things like that. And so you couldn't pry my hormones out of my cold, dead hands, but doctors are quick to take you off of hormones because they will say a lot of times that they cause problems in the gut. Is there anything you know about
Zoe
this?
is here. So the largest nutrition study in the world did stool samples of where is she? Where is she's back there? Yeah.
I will find you.
And they tracked the gut microbiome through the menopause transition, and what they saw was a complete dysbiosis and going to the gut of a man. Now, nutrition is huge here. And we know there's something called the estrobolome, like the liver's metabolizing, we get these metabolites, and there's this recycling thing that happens. So gut health is healthier on women who are on HRT, and they showed it. So you have the profile is healthier of the gut microbiome. There's so much exploding research here. And whoever's saying that is their opinion. There's no data to support that, and that is not fact.
Thank you. Yay, I can stand my hormones.
That was so great. I have both of their books, and I've gifted them to my friends who are like the Menopause. So it's never too early to start preparing, and it's never too late, so thank you. And there are a lot of questions. I know that you all have them. There's going to be another talk in June, so make sure you sign up for that. And just remember, some of the things they were talking about were those negative things that you hear. So we've all been there. You can hear 99 great things, but one person says one wrong thing, and you give that thought priority. So when you're having fear and anxiety about some of the scary anecdotes that you see online, just remember that, right? So please take a break. We're also going to talk about bone health at that talk later on, so save your questions for that. This panel is called It's Not All in Our Heads. We're going to be talking about some of the depression, anxiety, irritability, and insomnia in perimenopause and menopause. But before we start, we're going to demonstrate how it's not all in your heads, it's also in your body. And we're going to do some mind-body work. And I'm going to give you the gift that you already have. You just don't always utilize it. So what I want you to do is I want you to close your eyes, no peeking, and take a deep breath in through your nose. Through Through your nose slowly. Hold it, and then out through your mouth. And one more time, but this time when you do it, think about those tense neck muscles and relax them as well. So in again, and out through your mouth. You can open your eyes. We just demonstrated the mind-body connection. And breathing is something we all do, but some of us hold our breath so tight, and we do a lot of chest breathing. We don't do diaphragmatic breathing. But if we just take the moment to validate how we feel, and to acknowledge our feelings, and to process these feelings, we can just have better moments every day. And so I'm going to introduce the wonderful panel that we have today. This panel will unpack why we struggle with mental health issues, things like sleep, things like brain fog, irritability, anxiety, and they're really going to help us to explain this, but we're also going to get really useful tools. So make sure you take your notes, and again, share with others when you return home. So first, I'm going to introduce Dr. Kingsburg, Dr. Cheryl Kingsburg, and you'll see their long bios in your folders, but she's a clinical psychologist and professor of reproductive biology, psychiatry, and urology at Case Western Reserve University, and division chief of behavioral medicine in OBGYN at Cleveland Medical Center. Good to see you. Thank you. And Dr. Mackey, Dr. Pauline Mackey is the professor of psychiatry, psychology, and obstetrics and gynecology, and the director of the Women's Mental Health Research Program at the University of Illinois at Chicago. And Dr. Mackey just came back from DC after, advocating for women's health, so thank you.
Yep, pleasure to be here.
Please have a seat. Okay, so before we start, I really just want to understand what your key takeaways are. What are the most important things that we should be focusing on during this panel? And we could start with you, Dr. Mackey.
Sure. From my perspective, the main message that we have about mental health in the perimenopause is that if you happen to be a woman who has a history of major depression, and who has more major depression, men or women? Women, right? So as we go into the perimenopause, we're going to have more women with this history. The majority of those women will have a recurrence of their depression during the perimenopause. 58% will have that recurrence. So that means that for those women, it's really important to monitor your mental health, to have active discussions with your care provider, and to have strategies to plan around this elevated risk. And the idea is that if you have that history of depression, it's a recurrence, right? It's not a new thing. It's a recurrence. So it's the love the one you're with idea. Whatever worked for you for your condition prior to the perimenopause will work again in the perimenopause. So that's the group of women at increased risk, primarily.
Always hard to follow Dr. Mackey. I want to talk about the range of mood symptoms, that it isn't just depression, and depression isn't just depression. So we look at mild, moderate, and severe, and we look at anxiety. When we think of, for example, about postpartum depression, anybody in here have a postpartum depression? We think about two flavors of postpartum depression. We think about anxious, and we think about flat. And the same thing is true with menopause. There are many women who will have panic attacks. We learned about that before. And there are many women who are going to develop depressive symptoms. And unfortunately, if you go to your women's health provider, a gynecologist, sometimes primary care, they often dismiss it. We're trying to get it out of it's not just in your head. Or they'll tell you to go on a nice tropical vacation or just relax. And while breathing and mindfulness exercises can help, and look, I'm a cognitive behavioral psychologist. I do CBT for a living, and it is very helpful, but sometimes it's not enough. And we look at the biopsychosocial nature of menopause and menopause symptoms. And with that are the mood disorders. And so sometimes cognitive behavioral therapy will be enough. And sometimes pharmacotherapy will be enough, and sometimes hormones will be enough. And what's interesting, as we've been talking a lot about hormone therapy, we've been talking and how really valuable it is, but with premenstrual dysphoric disorder, with postpartum depression, and with menopause-related mood disorders, even though they are hormonally driven, the hormones are not always going to be the treatment. So not only psychotherapy, but sometimes you do need those antidepressants and other CNS drugs to address what is a hormonally based condition. So you need somebody who knows what they're doing and who is willing to listen, and please do not stop at that person if they say, oh, it's all in your head, just relax, it'll go away.
And Dr. Kingsberg, before we go to those treatments, how important is it to figure out which factors are causing the specific symptoms? Because sometimes it's confusing when you have a lot of symptoms at once.
Well, keeping in mind that biopsychosocial nature, which also helps you determine where you're going to go for treatment. If you're having anxiety, it's always helpful to start with somebody who knows how to treat anxiety. And by the way, panic attacks, which are very common, are different than anxiety in a real condition. And can I please use you as an example, sure. Dr. Mackey? So Dr. Mackey was in a plane last night where the engine blew up. And she was anxious. That is not a panic attack. Right? A panic attack and sitting up in front of you and going blank because my postmenopausal brain, right? Could that be a panic attack? Maybe. Or could that be real anxiety because I've got a whole bunch of people staring at me? But panic really is when your body signals that it's in danger, right? It's a fight or flight response kind of thing. And if there's no bus about to hit you, or a saber-toothed tiger, which is where this comes from, that fight or flight, about to eat you, and I am going on safari in June, so that, again, would be not a panic attack. But without those, we have smaller things that trigger anxiety. And so those are the things that we can manage, and we can manage it in a variety of ways. It is always helpful to go to the provider you think is the one you trust, and you and that person together can decide, do I need psychotherapy? Do I need pharmacotherapy?
And you said biopsychosocial. That's something a lot of us learn in medical school, but I think it's really useful for non-medical graduates to understand those three buckets. Can you please just go into that a little further?
Sure. The biology would be the hormonal and neurochemical milieu that creates the physiology of those symptoms. But there's also psychological factors that contribute to how we interpret those physical symptoms. So, and what's going on in our lives? Do we have depression? Are we struggling with relationship issues? And then we have sociocultural factors. What our society tells us should be what we are also impacts, how we react and what our mood symptoms might be. So biology, psychological factors, and sociocultural factors and interpersonal factors all contribute, because how we relate to our family, our partners, if we have one, all can impact those mood symptoms. And that's how we look to see, I do a lot of sexual medicine, so that's and they kicked me off the panel. But did I say that? But when somebody comes in and says, I have no desire, for example, sometimes it is biologically based. We've talked about low libido as one of the conditions. And so for that, we would look at the biology of it. But sometimes it's depression related. One of the major symptoms of depression is loss of sexual desire. It's loss of all things of interest. Sometimes it's our religious and cultural values that lead us to not want to be sexual. It's shameful, it's guilty. And sometimes it's our partner, right? You could have all the drive in the world, but if you don't like your spouse, you're not going to want to sleep with that person. So that's how we tease out what treatment approach we're going to look at, right? We want to look at, does it seem to be more biologically based? Because I'll see women will come in and say, everything in my relationship is great. We're shared values, everything's great. but I don't have that drive anymore. I've lost that biologic urge. And I have other women who'll come in and say, yeah, I have drive, I masturbate, but I don't really like to have sex with my partner. And so that makes it very easy for you and your practitioner to decide which direction of treatment you're going to go. That's what I mean by biopsychosocial.
Beautiful, thank you. And so we're looking at this slide, windows of vulnerability. Dr. Mackey, can you please just take us through this slide and help us to understand what that means?
So we know that women have about twice the risk of major depressive disorder compared to men. They're also at elevated risk for anxiety. This vulnerability actually comes online at puberty. So one of my absolute favorite studies, because I think it's so elegant, is a study by a researcher, Monica Ernst. And what she did is she followed boys and girls as they went through puberty, and she said, what changes as they age and what changes as they go through puberty? And she looked at the way that the brain gets wired. Not surprising, the way that the girls' brains got wired differed from the ways that the boys' brains got wired, in that the girls' brains became more self-referential. What does that mean? When our moods are low, what do? We talk to ourselves, right? We have negative self-thought. I'm no good, that person did something, nobody will ever love me, this is never gonna work out. And it turns out that it's the inflection of estrogen and progesterone at that time that causes that circuitry to get into gear, okay? And the extent to which these girls showed this self-referential circuitry predicted who was gonna get depression. Because the more that circuitry got ingrained, the higher the girl's risks for depression. So what does that tell us? It tells us that these hormones affect the wiring of our brains. And that especially when those hormonal levels are changing, that's what our brains don't like. They don't like the change in hormones. It's not the level. It's the variability in estrogen and progesterone that the female brain doesn't like. It wants it to be completely flat. Okay, so that's the theory, okay? So what does that mean? When do our hormones change? Puberty, when else? Pregnancy, and when else? Menopause, right? Exactly. So you can get women who have this predisposition for self-referential thought, and when their hormones become variable, this kicks in. Now, is this all women? Do all women get postpartum depression? No. Do we know that it's hormonally driven? Yes, right? Same thing with perimenopause. Some women are going to be vulnerable to that hormonal influence on their brains because of the way that the brain is wired. But that's not a universal. That's not everybody's brains, and we know that from postpartum depression. So that's kind of the theory about why our brains become vulnerable at these time points. And there's this beautiful literature that shows they actually measured estrogen levels every day for 8 weeks in women. And they said, what predicts how irritable she is during the perimenopause, what predicts her anxiety, and what predicts her depression? And it was the women who had the most variability in their hormones during the perimenopause. So, what does hormone therapy do? It flattens that out. What do oral contraceptives do? It flattens it out. So for women whose depression and anxiety is driven by that variability, going on one of those therapies should help, because you've dealt with the trigger, the thing that's making their thoughts self-referential. If going on that therapy doesn't help, then was it the estrogen? No. So then we go with an antidepressant. But the first line is typically an antidepressant. Now, it's not just those variability factors that influence our brains at these points in time. It's the other stuff that comes along with variable hormones. What's that? How many are sleep deprived? I'm sleep deprived. Yeah, what's your mood like when you're sleep deprived? Are you peppy and somebody cuts you off in traffic and you're like, oh, go ahead. That's fantastic. No, please, be my guest. No, we're punchy. We're punchy, and what happens when we're sleep deprived is that our prefrontal cortex fails to put the brakes on our amygdala. When your friend says something nasty, or maybe not a friend, a frenemy, says something nasty, and you're like, no, I'm not gonna react. You know, I'm gonna go to that happy place. That's your prefrontal cortex saying to your amygdala, stamp down. No, we're not gonna go there. Those areas work in concert when we've slept well. But when we haven't slept well, they don't talk to each other. And that's why we get irritable. So the sleep deprivation is a main factor. What causes sleep deprivation in the perimenopause? Hot flashes. So my dear friend and colleague, Rebecca Thurston, discovered that 70% of the time that you have a hot flash when you're sleeping, you wake up. So the hot flashes can trigger these awakenings, right? So if your sleep is disturbed because of the hot flashes, that hormonal variability is going to be a particular trigger for you, right? So you have to treat whatever it is that's causing the sleep, because when we haven't slept well, night after night after night after night, we're going to get punchy and we're going to get depressed. And you don't need a PhD in cognitive neuroscience to tell you that.
Can I also add, though, that even women who have mild vasomotor symptoms may still have sleep problems.
Yes.
So while hot flashes will wake you up, so will other things in perimenopause. And so sleep is or insomnia is a very common symptom. And so don't think that you're crazy if you're not having a hot flash and still waking up.
Yeah, in fact, most of the times that you wake up in the perimenopause and the postmenopause, it's not triggered by a hot flash. So your waking after sleep onset is exactly that. It's part of what we go through, unfortunately.
And your explanation was so helpful while having that visual, because many of us are visual learners. So seeing you talking about the fluctuations and then showing the visual of the hormones, that really helps to solidify the information. So help us to understand some of the other neurobiology behind some of the symptoms that we experience, Dr. Kinsberg.
You're asking me to explain Dr. Mackey's experiences. I'm going to let her take over and talk about neurobiology.
So in the brain, our estrogen, so we have estrogen receptor alpha and beta, 2 types, why not? Okay, and they're located right next to our serotonergic receptors. And when things in the brain are located next to one another, there's a reason. They tend to function together. And so estrogen does this dance with serotonin. So what do the treatments for depression do? They increase our serotonin, right? Estrogen also increases our serotonin. So there's this nice dance between hormones and brain chemicals that are critical to our depression, okay? But there's something else really special about being female chemically, and that is progesterone. So how many of you have heard about the new treatment for postpartum depression, that pill, right? First time there's a pill for postpartum depression, and it works within 15 days. And the thing that it does is it gives us more of a breakdown product of progesterone. So our bodies metabolize hormones. They have what are called metabolites. One of those is something called allopregnanolone. And if I were to give you allopregnanolone, you'd feel kind of like what you did when you breathed. There'd be this nice calm, but you might get a little sleepy. It's elevated in pregnancy as well. So progesterone plays a role as well. And that breakdown product of progesterone plays a critical role in our moods as well. So it's estrogen, it's progesterone, and it's the brain chemicals that work in concert with those two that really influence our mental health in the perimenopause.
Can I also add sleep?
Yeah.
When postpartum depression, the first treatment of choice is sleep, if they can get it.
Yeah.
Because how I describe it is whether you're going to use the new drugs or you're going to use SSRIs, if you don't have sleep, to me it's like taking the medicine, pouring it into a bucket with a hole in it. And so that sleep sort of allows the use of those chemicals in the brain.
So before we go to treatments, how important is it to figure out which factors are causing the specific symptoms?
Sometimes it's not always that important to know exactly what. What you need to do is to be able to describe the symptoms, because you need somebody to help you figure out where you want to go with the treatments. First of all, it's never going to hurt to have cognitive behavior therapy. It really doesn't hurt. And it is often an adjunct, even if it's not going to be the only treatment. It is often a very helpful treatment. What people worry about is that you'll be in therapy too long before you get to a medical treatment or a pharmacologic treatment. And trust me, a good cognitive behavior therapist knows when it's not enough. So if I see somebody I get referred I work in an OBGYN department. So my colleagues are referring patients all the time, whether it's for postpartum depression or PMDD or menopause-related mood disorders, and I know very quickly that cognitive behavior therapy isn't going to be quite enough to address their symptoms. At that point, shared decision-making. This is not just me telling her. It is shared decision-making to say, I really think a pharmacologic option might be helpful. And then it becomes, do we do hormones or do we go to an antidepressant? Some of it is her choice, and some of it is, getting a sense of whether it's the fluctuations that Dr. Mackey was talking about that makes sense, like in perimenopause, which is the time, I've learned from the best, that it really is only in perimenopause that you can use hormones as a potential antidepressant, right? Because once they've settled out, postmenopausally, it will not help. But some women really will respond to hormone therapy to address their depressive symptoms. And that's a fair thing to try. And the antidepressants can also be used as well. So you have some options there. And it really is individualized. It is not a one-size-fits-all. So it's about you and shared decision-making.
May I add a neuroscience perspective on what Dr. Kingsburg just said? So do you remember how I said the prefrontal cortex puts your brake on your amygdala? If you do a brain imaging scan of people before and after CBT, do you want to know what you see? The prefrontal cortex puts the brakes on the amygdala more. It's not talk therapy without some kind of brain change. The reason CBT works is because it changes your brain wiring, just like a pharmacotherapy treatment will, right? So thoughts are powerful things. And if you get the brightest people, and I'm not just saying it because she's next to me, the brightest people I know do CBT. You have to be really, really smart to do CBT. And when you get a good CBT therapist, they will help you rewire your brain, help you think differently about your thoughts. And it's a powerful biological tool.
I'm glad we're spending so much time on sleep, because sleep, like breathing, is free. We all do it, whether we want to or not, right? How many of us used to brag about pulling all-nighters, and we wore it like a badge, and now sleep is so sacred. And sleep is important because with poor sleep, you have poor mood, you have worsened anxiety, you have poor health issues, you have poor thinking, right? It's hard to concentrate. So we're gonna spend some more time in this area on sleep. So Dr. Mackey, what are some of the main sleep issues that we need to be thinking about?
Wakefulness after sleep onset, otherwise known as WASO, increases in the perimenopause. So what does that mean? It simply means, I really wish I was sleeping, but I'm awake. That's what it means. That's the sleep symptom that women report and that we measure using fancy polysomnography and actigraphy. So we measure sleep objectively because we want to think that we know what's going on in our bodies, but we don't always really know how well we slept. So in our research studies, we use these objective tools. And when you follow women from the time they're premenopausal to peri to post, you see this increase in wakefulness after sleep onset, and it actually persists into the postmenopause. It's one of those symptoms that for many women doesn't get better. And we know that from large longitudinal studies. There are other aspects of sleep that can get worse, but the frequency of those symptoms is lower. That includes things like not being able to fall asleep, right? And there's this kind of special mixture of the special storm that happens in the perimenopause. So let's think about the last time we woke up when we wanted to be sleeping. Okay, got there? Did you go to La La Land? No, you started ruminating, right? You started thinking about everything you needed to do. You go into this negative thought process as well. And unfortunately, the hormone variability puts us there more. So it's this perfect storm of waking up and then ruminating. And that's kind of a special thing about the perimenopause. And I'm sure Dr. Kingsburg will be much better than I ever could in talking about CBT for insomnia and how that's a particularly special tool in kind of taking away that cycle of sleep deprivation.
And Dr. Mackey, there's also, people who have higher risks of sleep apnea, and that's
Yes.
one thing we don't think about
That's
as
right.
we get older.
That's right.
Is a part of it contributed from sleep apnea.
Absolutely right. So we run a longitudinal study called Ms. Brain, cool name, right? Ms. Brain, and we have women wear our objective sleep monitors, but they also wear sleep apnea monitors. And I would say 50% of the women that we detected in had no idea that they had sleep apnea. And you know what happens with sleep apnea is our oxygen gets cut off. And so it's really not particularly good for cognition. So I'm so glad you brought it up because this is a modifiable risk factor for our brain health, which we want to optimize at midlife so that we take the healthiest brains we can into our later years. So let's treat that sleep apnea and treat the sleep deprivation.
Thank you.
So how many of you share Wordle with a friend? Do you have a little, right? So my friends know when I have WISO because Lisa's on my little group thing. And so at 2 o'clock in the morning, when I wake up, and one of my ways of managing the rumination is to do something distracting. In the old days, it used to be a crossword puzzle because you can do a crossword puzzle and not have to finish it. You don't want to read a good book. You don't want to watch TV. You don't want to do something that's going to engage you. You want something that will shut down those ruminations. So sometimes I will give people a homework assignment of taking a pad of paper and dumping, it's a data dump, take all of those ruminations, which I got to remember to do this and don't forget to do this. If you put it on the paper, put it on the back on the bed, you're good. But mine is to do Wordle, because it takes just a couple minutes, because I can usually do it in 2. You said I was smart, and then I send it off, and then they'll say, "Why aren't you on hormones, Cheryl?" Or what, are you not getting good sleep? Because 2 a.m. is when that happens. So, just a comment.
And you feel really good about yourself too.
That's right. Yes, if you can get it at 2 a.m., that's impressive. But CBTI really is very helpful. It is evidence-based, and cognitive behavior therapy is evidence-based. And to Dr. Mackey's point, it really is about taking negative thoughts, beliefs, feelings, and behaviors, and working. It's a collaborative approach. It's not just passive. You and the therapist work together. Not because I'm lazy, but it works better when you work together and you alter those negative thoughts and you shift them. So for example, if you're panicking, what if I have a hot flash in the middle of a board meeting? That can create its own stress, and we know about thermoneutral zone, right, which is one of the reasons we have hot flashes is because thanks to that loss of estrogen, our thermoneutral zone of what our body senses is a good temperature changes, it narrows, and so if we go above that, the body says, whoa, we need to sweat you so that you can shiver and cool the body down, and so your stress level can also narrow that, so it's a double whammy. So if you're now worried about having hot flashes, you can actually help that along. And so it is how you manage the thoughts, the what ifs. Anxiety has a lot of what ifs to it. Even if you don't literally put a what if to it, it's about what ifs. And it's not what if I win the lottery. It's always in the negative direction. And it's usually catastrophic. And it makes sense. We as women tend to prepare for things, and it's an insurance policy. If we can create a what if that is the worst case scenario, our belief is It is an insurance policy to prevent how that will impact us. If I think about the worst and every possible negative scenario, then I'm ready for it. The trouble is you have now zapped all of your energy in that preparation, and it's always going to be something else that happens, not that 1 in 100 things that you'd thought of. And it doesn't help to have prepared for it anyway. It's not going to make you able to handle it better, and it won't hurt less if you get some bad news. It just zaps you when you're busy ruminating. So part of cognitive behavior therapy is to actually do the math, figure out whether it makes sense to have those negative thoughts, and if not, to find ways to alter them to more neutral and positive ones, to give you back control over your life.
And can we just take a step back and explain to everyone what cognitive behavioral therapy is? Because we brought this slide on, and there are different therapies on there, but we're really singling out CBT, cognitive behavioral therapy, because it's so practical. You could do it anywhere, and it is so powerful. It's something that when you learn and you practice, it can be with you for a lifetime. So can you please just take us through what the basics are?
Sure. Well, like I said, cognitive behavior therapy is a collaborative approach where you learn to identify those common negative beliefs and behaviors, because we also engage in pretty self-destructive behaviors, that are disruptive to our lives. And first you have to notice them, learn about them, and then, thanks to Dr. Mackey explaining to us that we have neuroplasticity, we can actually change how we think about things, really alter those beliefs and thoughts and the behaviors that go with them. And sometimes we have to, it depends on which direction we go first. Sometimes, and we see from the slide here, it's not always that it's always in the same direction. Sometimes we alter the behaviors to help us change our beliefs and our thoughts. And sometimes we can change our thoughts, which will then engage us in better behaviors. So prime example for, say, activation, because behavioral activation is part of this, is exercise. And look, I exercise almost every day. I don't like it. I don't want to. I have no intrinsic motivation to do that. And so if I waited for the actual interest and motivation, that would never show up. So I know better, right? And so now I go to the gym, I put on my workout clothes, I get on the treadmill, and only then does a smile come on my face, and I think, oh, this feels good. But if I had waited for the thought to get me there, it wouldn't happen. And so, but I've now done something that really will benefit my mood, because it actually does. And so in the other direction, though, as we said, activating and doing things that we enjoy can really be helpful. Think about what depression is. By definition, it is anhedonia, the loss of interest in things that bring you pleasure, and avolition, the loss of motivation to do things that are rewarding. When we get depressed, right, we lose energy, we get flat. Depression isn't sad. Depression isn't necessarily tearful. Depression is flat. We lose any sense of what's meaningful in our lives, and that's really depressing. And so we need the cognitions to change to be able to alter that, to recognize them as dysfunctional and not accurate, and we need the behaviors back in place, because you'll say, oh, come on, play golf with me. I know you love golf. No, I don't feel like it. But if you get them out there, or if they know that that's their homework assignment, then they're like, oh, you know what, that was actually pretty good. And that reinforcement helps with the mood. So it goes in all three directions to alter the cognitions and to alter the behaviors.
And I'm glad that you talked about exercise, because we were just about to segue into medications, but before we get there, these natural things that we can utilize to support us are so important, and sometimes we forget them. Things like what we eat. Certain foods feed our brain so that our neurons, our brain cells can work better, so that we have less anxiety and depression, less sleep issues. Certain things like, getting rid of that pesky light in the room. I've been traveling a lot, but I call myself the light hunter. When I go to hotel rooms, I'm searching for the light, and I have a tape to cover it up, because there are things that are within our power and our control that we can do from a lifestyle standpoint. Getting rid of toxic habits like smoking, excessive drinking, and toxic people. Those are all lifestyle things that we can utilize to support us. But we will segue to medications because some of us will need medication support, and that's okay. All of us won't, and we want to cover that. So Dr. Kinsberg, when do you think it's the right time to start exploring medication?
Well, I think, a lot of times people get sent to me by their physician often, and they'll say, does my patient need medicine or do they just need cognitive behavior therapy? And for example, with postpartum depression or with a serious depression, sometimes I want them started sooner than later to kind of kickstart the shift. Because when I think about what an antidepressant does in combination with cognitive behavior therapy, is it turns down the volume on the rumination, on those what ifs. And it gives the brain a chance, as you put it, to get that prefrontal lobe kind of connected so that they now have a chance to turn the volume down to say, do I really think that? Because they are so automatic. Those thoughts and those ruminations are so automatic, you don't get it, you're just bombarded with them. And so it gives me a chance to do my best cognitive behavior therapy when I can help them turn down the volume. And sometimes medicine really does that. Now, I have many women who'll say, I'd really like to not do medicine first, and I'm willing to start them there. But if I really see them sort of sinking into not being able to engage with me or do some of these behavioral things I want, I'll say, you know what, I really think that medicine is for you.
I found the same thing in my practice, and sometimes people have histories of trauma, right? And so they're constantly in fight or flight, or other times there's an undiagnosed ADHD, so we have to address that with stimulants. And not everyone can jump into cognitive behavioral therapy. It's great, but some people need support beforehand because there's homework. It's hard work. The saying, do the work. There's work involved, but the work pays off. And Dr. Mackey, what do we know about the most effective treatment for depression during the menopause transition?
So if we take this idea that the people who are most vulnerable to major depression, so this is clinical depression, the sad news is we're all vulnerable to an increase in depressive thoughts and symptoms. That might not make that mark of clinical depression, but they affect our lives, right? If we're feeling a little less interested in things, even if we're not in major depression, it still affects our quality of life, right? That's not what we want the antidepressants for. So we're talking about clinical depression. And for those depressive symptoms that don't meet the criteria for major depression, we want to engage in the exercise. We want to refrain from having that second glass of wine, right? Because the effect the next day, especially if you're estrogen deprived, is even worse on your mood. So it feels better in the moment, but we also have to avoid that, right? And friends trigger dopamine. That's why we're always looking at our phones. Our friends make us feel pleasure. So we want to engage socially with people. How many of us have felt down and your friends are like, do you want to go do something? And you're like, no, I'm really not. But then you do it anyway. Do you regret it? No, right? That's part of that behavioral activation. Okay, so I just want to distinguish between elevated depressive symptoms, where you want to use those behaviors, and major depression when we're thinking about medications. So if we go only to the randomized trial data, there are 2 large randomized trials of antidepressants. Venlafaxine works. But then there are 10, 20 additional trials that show that basically they all work at this point in time. It's just that venlafaxine has the most data to back it up based on clinical trials. And sometimes you want to pair that with a hormone therapy. So if you're chronically sleep deprived because of hot flashes and nighttime awakenings, you want to pair the antidepressant with a hormone therapy so that you have both of those causal arrows, if you will, into your depression taken care of. Antidepressants might take away 1 or 2 of your hot flashes. That's all it does when you measure those hot flashes objectively. They don't really take away a lot of hot flashes. They take away 1 or 2. So you need to treat that as well, right? So you have to think about, am I depressed? Is it more of a neurochemical thing? Is it more of a serotonergic thing? In which case I might want an antidepressant. Or is it also my menopausal symptoms? And then you need to treat that as well. Okay, so both arrows are important. And then I think CBT, all of us should have it. Honestly, we all have negative thoughts. I think everybody should have some type of therapy at some point in their lives for that. So those are the major treatments for depression. And again, it's the love the one you're with, right? Use whatever you used in the past, and then think about adding on a hormone therapy if you have those menopausal symptoms. The reason that's important is that studies have shown that if you monitor women and you measure their mood, that my hot flashes on Monday predict my mood on Tuesday. So it triggers over time in that way. It's not the opposite, interestingly. The studies haven't supported that. So we need to prevent those depressive symptoms by getting good sleep and treating those vasomotor symptoms if they're moderate to severe as well.
I'm glad you brought up sleep because we talked about hormones, right?
Yeah.
We talked about antidepressants. What are some of the options to support us when we're having sleep issues?
Gold standard, according to the American Academy of Sleep Medicine, is CBTI, cognitive behavioral therapy for insomnia. Do you withdraw from that? Once you know how to stop those negative thoughts, you use those practices again and again and again. Once you're off of a sleep medication, do you get the benefit from that sleep medication? No. And that sleep medication doesn't restore sleep as we know it. It makes you sleep, but it doesn't create the same stages of sleep. The architecture of sleep is not the same on sleep medicines. I think they have a role for bereavement, right? When we just have to get sleep and it's this biological instantiation of grief or some major stressor to help us through, but it's not a long-term solution. And another really important tool in our armamentarium for sleep in mood is taking your progestin at night. So we have this receptor called GABA, and it inhibits our brain functioning. It quiesces them. And that's what benzos work on. They work on that receptor. They decrease the activity in your brain. And that's exactly what progesterone does. It works on that same receptor. So that's a powerful tool if you take it at night. It can help you to kind of relax and be calm.
And you mentioned GABA, and there is a medication called gabapentin. There's trazodone. What are those some good options for people to consider?
What's your clinical experience with those?
If you don't, I find them very sedating. So it would not be my first choice.
Mm-hmm.
Too much GABA.
Great. And the other thing is that, you're right, some of these medications cause withdrawal, so there are risks associated with that, and you should know about that before.
Right.
CBTI you can get online, so you don't necessarily have to find the right practitioner right in your city. You can actually, there are some good websites, which please don't ask me right now because I'm going to have a blank moment, but there are very good CBTI programs online, so they have already been established.
Dr. Kingsbury actually just practiced a skill right there. That's a CBT skill that she just did, right? She said, I'm having a moment, I'm forgetting a word, and she just said it, right? Did any of you think twice about that? No. What happens is, if you actually go and you say, oh my God, I'm forgetting the word, you get really distressed about it, I think I have Alzheimer's disease, I think, what's wrong with me, right? So the more you fight that, the worse the symptom is. So she actually just did CBT on herself in that moment. Same thing when you're having a hot flash, right? If you say, what's that?
Do you think I have Alzheimer's?
No.
I do not think you have, no. That's a catastrophic thought, right? And so then the other thing is, and I'm a therapist, I'm a CBT therapist, you can tell. The other thing is, the same thing with a hot flash. I'm having a hot flash right now, right? You're at work, instead of fighting it and being embarrassed about it, and being like, oh my God, I'm having a hot flash, I have to hide it, right? What am I gonna do? I'm so embarrassed. I'm having a hot flash right now, right? People are less likely to judge you when you actually say that than they are when you're actually trying to hide it. So those are like some practical skills. I'm just saying that because I'm a therapist and I need to put that in there. But we're going to take some questions and answers now, I think. So who wants to start? Who has a question about mental health?
Or who doesn't have a question about mental health?
I know you mentioned it briefly, but can you say more about sleep, if you have trouble falling asleep versus if you wake up during the night? I typically, if I wake up, it's because I have to go to the bathroom. I can go to the bathroom and go right to sleep. It's the falling asleep part that trips me up. Are there different mechanisms or different ways we can think about trying to address that?
Well, first of all, there's sleep hygiene. So you need to make sure that your bedroom is used for sleep and sex.
Sex.
I was not going to forget sex. Sleep and sex. And as the dark, what did you call it?
The light hunter.
The light hunter, you need to make sure that it's dark and cool. And then there is the mind issue, right? Like I said, oftentimes as soon as it gets dark and quiet, then all the voices come in. Not auditory hallucinations. These are the thoughts of what do I need to do, what happened today. It is the past and the future. And really a mindfulness approach to good sleep and falling asleep is to stay present because the background noise of what happened and what goes forward is going to keep you spinning. And that is, if you need some help with that, I really do think putting it on paper, giving yourself no more than 10 minutes, usually 5, to dump down on paper, and it's actually helpful if you write it, not type it, because you don't want the blue screen stuff anyway. Write it out, and you can say what you were obsessed about of what happened to you today, or what you're worried about tomorrow. It really can sort of cleanse you. We wash our face, we brush our teeth, we floss, but we don't often dump all of that stuff that's in our heads, and that can be really, really helpful. If you can't fall asleep within 20 minutes, you need to get up, do something else, take a break, because if you sit there watching the clock, that is a terrible thing to do. That will just get that all started all over again. And then there is Wordle.
And we also have to train our brains that it's time to sleep. So we have these circadian rhythms where our bodies get used to and predict and know that something's going to be happening, this is my rest time. So a really important part of sleep hygiene is trying to go to bed at the same time every night, regardless of whether it's a weekend, because your body learns it's bedtime. There is a learning mechanism, and just building that habit is very important. And that can help us to fall asleep because it's like, okay, your body says, oh, this is the time that I fall asleep.
Yep.
And also creating a sleep cubby, a sleep haven. Some of us, if we invest in like really nice pajamas, soft sheets, things that make us look forward to sleep so it's an experience and not just something to do, that also trains our brains to acknowledge sleep as being so sacred, because it really is.
I need new jammies.
Who else has a question? You have anyone over there? Oh.
So I just recently started taking hormone therapy, and I'm having an effect. I don't know if this is common or if it's maybe not related at all, but the progesterone actually wakes me. So I wasn't necessarily having sleep issues, and then I started having sleep issues with the progesterone.
How do you know it's the progesterone and not the estrogen?
Well, because I know I'm not supposed to, but I was just going crazy because I couldn't sleep. So I didn't take my patch off, but I did stop taking the progesterone for 2 days. It was also giving me crazy anxiety.
Yep.
So that's my unscientific.
Yeah, so how many of us have tried an oral contraceptive at an earlier point in our life and we become, what's the pleasant word? Irritable, right? And then you switch to a different progestin and you don't have that effect. Yeah, sometimes these are class effects. Sometimes it depends on what your progestin is, and we can find that we can switch that. Not to get too technical, but it actually changes how the GABA receptor works, what's influencing its modulation, so different progestins. So you can try a different progestin. And some of us are just sensitive to them. And really, you know, if we're sensitive to progestins, then we can do a vaginal progestin instead. Right? That's a really good option because then our brains never see it, if you will. So you might try that. If you find that you're sensitive to a progestin, you may change the route of administration and try to do a vaginal progesterone and see whether that's a good option for you. Yeah.
First, thanks for all of your information. I've been dealing with insomnia for many years, and I've used a lot of the suggestions that you have said. And I also take magnesium at night, which I find helps. I wake up at night, and I don't necessarily have anxiety if I take magnesium. I'm just simply awake. Like, my body thinks it's time to get up multiple times a night. It's just, oh, let's get up. It's morning. Does that mean it's not hormonal? Does that mean... What does that mean specifically when you're just awake without anxiety?
I don't know that we can attribute a specific sleep episode, whether it's an awakening, to one particular neurobiological source in that manner. But what we do know is that we can have those awakenings after sleep onset without the anxiety, and it's still a menopause symptom. In other words, not everyone does that. And that can happen after CBT, right? We can decrease those negative thoughts, but it doesn't necessarily mean that we don't have those wake episodes. It's just that rumination keeps us awake for a little bit longer. So if those sleep episodes are common and you feel energized, the guidance is to get up out of your bed, go to another place so that your brain learns that my bedroom is my sleep space. So there's some ideas about the importance of sleep hygiene with respect to these episodes. So if you know that when you wake up, it's going to be a good half hour, some sleep experts will recommend to you that you actually move yourself physically from that room so that you can go back to this sleep place when you're not so energized.
And also one of the things I've done with my clients who have a hard time with sleep and we can't figure it out, I ask them to start keeping a journal about what they're eating during the day, what they're doing during the day. And that can sometimes help you because in some cases, some of my patients were taking supplements or things that they didn't know had caffeine in them, and that was contributing to the sleep issues. And then and also it gives you a sense of empowerment because you're actually doing something and you're bringing information to the doctors. And if we still have a hard time, then I work with sleep medicine colleagues because there may be something else going on and they may need a sleep study or they may need help with sleep apnea because, not everyone who looks like they should have sleep apnea has it, and some people who look like they shouldn't have it have it. So we just want to be sure that we're covering everything.
Wait, so we have a question from our online community. So the question is, can OCD symptoms increase during perimenopause in women who have struggled with these symptoms in the past?
Yes. Absolutely. Because, again, you could have anxiety symptoms, you can have depressive symptoms. And just like Dr. Mackey said, if you have a history of depression, then it's going to be an increased risk at menopause, perimenopause, and the same thing for OCD symptoms. They follow in that same brain chemistry pathway, and it's the same thing for postpartum depression. If women are prone to anxiety, they're going to very much have anxious symptoms during postpartum. It's, what if I hurt my baby? What if I forget my baby? What if? And they are very anxious, catastrophic thoughts. And so that OCD checking and worrying, and especially if you're worried about your memory now, it will tend to increase that anxiety about checking. So it's a double whammy.
Yeah, and we've talked about depression and anxiety because they're the most common conditions. But schizophrenia changes. At menopause, we published some work on that. manic depression does. And again, it's because the female brain doesn't like this variability. And our emotional regulation neurocircuitry, our prefrontal cortex, putting the brakes on the amygdala, is part of many different mental health conditions. It's not just unique to depression and anxiety. So any woman entering the perimenopause with a history of one of these psychiatric conditions really can help herself by having a conversation with her provider as she's entering it and saying, you know, I understand this is a period where I really need to make sure I don't have a lot of fluctuations in my hormones for that reason. These neurobiological circuits overlap. You know, the depression circuitry overlaps with the schizophrenia circuitry. The anxiety is part of OCD. So it's all of a piece, right? So we don't want to get too focused on what we call taxonomy, on categories of mental health disorders. This is a general period of flux for the brain. So that means that a lot of different mental health conditions and symptoms will be affected.
ADHD, PTSD,
Yes.
all of these things, you know, it's helpful to know your history. With my patients, we do a tree, so we look at the family tree and we draw it on the branches, your life experiences. There's something called ACEs, right? Adverse childhood events. But with adults, when we have adverse events, that impacts our outcomes as well. So we want to think about all of these things so that we can best predict what will happen to us. The same way that I do with my patients who are about to be expecting a child, my patients who have schizophrenia, who have bipolar, who have a history of PTSD, we talk about what to expect as they approach perimenopause and menopause.
We have time for one more question.
I talk with a lot of women who are just trying to figure out, am I in perimenopause? Is this happening to me? What's real? But the thing that I'm finding most interesting, and I'd love to hear your thoughts on, is so often the response I get from women is fundamentally, I'm not allowed to have needs. So therefore, that's great that there are people out there doing this perimenopause work and that are helping, but I'm not allowed to need that kind of help. How do you start to address that? And how do we in this room start to address that pervasive?
Amen. So let's talk about how do we know when we're in perimenopause. So the gold standard criteria are something called straw plus 10. You don't need to know that. You don't need a test to tell you if you're in perimenopause either. You don't need to spend any cash on that. Unless you have an endometrial ablation or a hysterectomy. But let's say for most of us who don't have that. Your menstrual periods change in the perimenopause in fundamental ways. So as we go from our reproductive years to our late reproductive years, whatever our cycles were, that was normal. Let's say we bled heavily on day 1 and then kind of tapered off. When that changes, you're still premenopausal, but you're in something called the late reproductive period. And that tells us whatever was normal for me with respect to my menstrual cycles is changing, okay? When you enter the perimenopause is when your menstrual cycles become less predictable in terms of their timing. So let's say you got your period every 28 days. And then suddenly the next period comes 35 days later, and then the next one 17 days later. The regularity of your menstrual cycles change, and that's when you're in the early perimenopause, okay? When you start to skip cycles, I went a whole month without my period. That's when you're in the late perimenopause, okay? And then when you go 12 months without a menstrual period, you back it up to the day after that last menstrual period, and that's the day you became postmenopausal. You don't know for 12 months, and then it goes backward in time, okay? So that's how you know. Now, you may need tests if for some reason your menstrual cycles aren't regular for a variety of reasons. You're on a long-acting contraceptive, or some medication that you're on is affecting your cycles, or you have PCOS, or you've had a hysterectomy. Then you might need a blood test to tell you whether your FSH levels some way or your AMH levels is another way. But that's how you know. It's simply knowing what your periods are like and changing them. That's how we know if we're perimenopausal or not. Now, this idea that I can't have anything about me, yeah, that's a sex role that we all have, right? I actually like to say to my daughter, I have a 15-year-old. The universe sent me the child I needed. She's this laid back hoodie girl, you know, she's just the, thank you universe for sending my daughter to me. And when she went through puberty, she'd apologize. That's how good of a kid she is. She'd say, oh, I'm so sorry, Mom, my prefrontal cortex isn't working well. She would, because she's my kid. And I said, you know what, sweetie? I don't ever want you to apologize to me for being irritable when you have your period. I want you to just say, I've got my period, I'm irritable, that's it. Like, do men apologize for being hangry? Oh, excuse me, darling. I'm hormonal right now. I'm a little irritable. You know, it just doesn't happen. So I think part of this is that we need to own and label and say, yeah, I'm going to be a little irritable right now. I'm in perimenopause. Now, there is something you can do about that irritability, which is to level out the hormones. And we saw that in a beautiful study out of UNC. But I think we have to bond together and say we're not going to just suffer through this thing together. We're going to talk about it. We're going to look for solutions, and that's the whole point of today, isn't it? We're going to normalize it, but I don't want women to always apologize for what happens to them hormonally either. Go ahead, label it. Take responsibility for it if you're, you know, unkind. But try to be kind to yourself and recognize, you know, I'm going through something. This is biology, you know?
Thank you. Thank you, Dr. Mackey. That was a great way to end it. Validate the mind-body connection, and I hope that you all learned something wonderful today.
It's a great panel. Okay, I'm back again. But this time we're going to be talking about sex. We're going to be talking about sex on the panel. We've got some incredible experts to share with you. So let me come on up here. Come on over here while I introduce you. Stephanie Pendergast is a pelvic floor physical therapist and co-founder of the Pelvic Health and Rehab Center with 11 locations, including Pasadena, where she sees patients. She was the first physical therapist to serve as president of the International Pelvic Pain Society and is co-author of the Pelvic Pain Explained. Welcome. Thank you. Dr. Samin Rahman is a board-certified OBGYN and founder of Center for Gynecology and Cosmetics. She is an assistant professor at Northwestern's Medical School and on the board for International Society for the Study of Women's Sexual Health. She also hosts a podcast called Gyno Girl Presents Sex, Drugs, and Hormones. Welcome. Somebody really liked that. Dr. Lauren Stryker is a clinical professor of OBGYN at Northwestern's Medical School. She is the founding medical director of its Center for the Sexual Medicine and Menopause, also author of 4 best-selling books, including Slip, Sliding Away, Turn Back the Clock in Your Vagina, and is the host of Dr. Stryker's Inside Information podcast. Good to see all of you. All right, we've been waiting for this one now as well because we had some great panels today. I feel like I've learned so much information and filled out that little notebook that they gave us. Dr. Stryker, I want to start with you because we hear GSM a lot thrown around. So can we just define it, what it is, and just kind of break it down for us?
Absolutely, and I'm going to stand up because I'm going to do a little show and tell here because we're going to be talking anatomy. So genitourinary syndrome of menopause are the physical changes and symptoms that occur in our genitals and in our urinary tract. Genitourinary. But basically it's what happens to our vulva, our vagina, and our bladder when our estrogen tank is on empty. And it's going to happen to 70% of you. So that's what GSM is.
I'm glad I asked. All right.
Because we get really, really tired of saying genitourinary syndrome of menopause. Yeah. But let's talk symptoms for a minute. Now, the panel's really going to be addressing all these symptoms. But what I want you to know is a lot of these symptoms, and we are talking not just sexual symptoms, but also just vulvar vaginal symptoms that are not sexual, and urinary symptoms. So many women think that these symptoms are just part of aging, because maybe their doctor told them that. But all of these symptoms are a direct result of a lack of estrogen. So what I'm going to do next is I'm going to walk you through some anatomy, because guys have the obvious advantage of being able to inspect their genitals with absolutely no effort on their part. And they do it all the time. For women, things are not only a little more hidden and a little more mysterious, but quite frankly, are very often taboo from a young age. So I'm going to walk you through all this, and we're going to start with what's going on in the pelvis. And this is a woman who has been conveniently cut open in half. And right here we have the front and the back. And let's start with the uterus, because that's the center of action right there. And then, of course, the uterus is attached to the vagina. In front of the uterus is the bladder, where urine collects. And when you need to go to the bathroom, hopefully not before, the urine will come out through the urethra. And then, of course, as we go backwards, that's where the bowels are, the rectum, and stool comes out of the anus. And then a very important part that also is not talked about enough, but Stephanie Prendergast is going to be talking about it a lot, is the pelvic floor, which is a group of muscles that supports all of this, and when they work right in a coordinated fashion, helps your bowel function, your bladder function, and your sexual function. So we're going to be spending some time talking about that as well. So under the theme of things that you cannot see, we're next going to be talking about the vagina. Let's talk vagina. So this is actually one vagina which we've divided in half to show you the difference. And keep in mind that unless you own a speculum, you cannot see in your vagina. All of us here, we get to look in the vagina, and I will tell you, it is not subtle, these differences. These are physical changes. So when any doctor, any clinician puts a speculum in, they are going to know, is this a vagina that has estrogen, or is this a vagina that doesn't have estrogen? So right over here we have the 30-year-old vagina, and the 30-year-old vagina has some nice pink color, and it's got lots of lubrication, and there's all kinds of these little ridgy folds here, these accordion-like folds, that allow the vagina to expand, to accommodate a penis, a toy, whatever, a baby if that's the part of your life that you're in. But then, post-menopause, these are not subtle changes. These are very dramatic changes. And it should only happen to your hips, but here is where things get thin. Thin and dry, really dry. And you lose those all-important little accordion-like folds, which means that you lose the elasticity, which is why things are not stretchy. You lose that elasticity. So let's move on to something that you actually can see. And this is the vulva. Now, 90% of the time when a patient comes in and says to us, oh, there's something wrong with my vagina, it itches, or I have a rash, or it looks funny, they're not talking about their vagina. They're talking about their vulva. No one can see their vagina. And this is something, again, we talk about taboo topics. How many mothers teach their daughters, wash your vulva, honey? Wash your vulva. You know, we don't even know those words. So the language is very important, which is why we're taking the time to go through this. So when we look at the vulva, and this is obviously a cartoon, it's not really what vulvas look like. There's wide variation, many, many different lengths of labia and sizes and shapes, and it's all normal. But when we start, let's start at the top with the clitoris, which of course is the source of most sexual pleasure. And then as we move down, we have the urethral opening, the labia minora, and the anus is down here, vaginal opening. But this is a part that we're going to be talking about a lot. And this is called the vestibule. And for many women, as we start to talk about sexual pain, the vestibule is the source of the pain. Women think, well, I'm using estrogen, I'm using a lubricant. Why is it still hurt? Well, because more often than not, you're treating the vagina. And it doesn't matter how nice the room is if you can't get through the door. The vestibule is the door. So we're going to be spending some time talking about that. So there you have it. Oh, one more thing. This is the important part. Why does all this happen? Well, it's because there are estrogen receptors every place. Everybody thinks it's just in the genitals, it's just in the uterus, it's just in the vagina. But in fact, and you've heard all morning about estrogen receptors in your brain, in your joints, in your skin. They are throughout the body, including the urinary tract. Lots of estrogen receptors there, including pelvic floor muscles, including the vulva, all of these areas, and yes, the bowel, but there are estrogen receptors and testosterone receptors throughout this entire area. So that's why we see these changes. That's why you have these symptoms. You are not imagining. We've talked a lot this morning about people are just kind of taught like, oh, you know, this is on your head. This isn't real. This is real. And that's why when you go to your doctor or your clinician, we like to use a mirror because it's very validating for women to see these physical changes and know that it's not just something that they're thinking. It's real. So now we're going to get real and turn it over to the panel.
All right, now that we understand, we have a lot more to talk about. Dr. Rahman, let's start with you. Let's talk about urinary symptoms, because that is something we touched on a little bit earlier. I heard some questions about it. How common are these during this time?
They're incredibly common, actually. I think at least 10% of women, 1 in 10 will have at least some urinary symptoms beyond menopause. Actually, some of the symptoms are even more common, like close to 80% of women get up in the middle of the night. That's called nocturia. There's pain with urination. So like that vulvar vestibule that we're discussing, you know, has the estrogen receptors, it has testosterone receptors, but the top part of that is right under the urethra. So people can sometimes have burning and pain when they urinate. They can get the frequency, the urgency, that I gotta go, I gotta go, I gotta go, and then they have the dribbling on the way. That's the urge incontinence symptoms. And then of course, just like recurrent infections, right? Like this is the big problem, right? Once women, I think it's what, 50% of women have recurrent urinary tract infections beyond menopause. And so it's a big problem. If you look at actually statistically, the statistic is 25% of geriatric hospitalizations are due to urinary tract infections. And so that starts out, okay, a UTI is what it starts out with, but then it can go to your kidneys, right? That's pyelonephritis. Then it can go to your bloodstream, and that's urosepsis. And urosepsis can kill people, right? Because I think it's 6% of patients, women with urosepsis, 6% of those patients that were admitted with UTIs can actually die from them. So I always say that the treatment we use for genitourinary syndrome menopause is life-saving because of that. Because if you're getting up in the middle of the night for nocturia, you might fall down. And then what happens when you break your hip when you're 80 years old, you break your hip because of your osteoporosis and osteopenia, whatever. I mean, there's a mortality rate of what's like 30% in the first year after you break your hip. So all of these contribute. And so the stuff that we're going to talk about treatment-wise, can be very life-saving.
Well, why does it increase? Why do urinary problems increase after menopause?
Goes back to the hormones, right? We have estrogen in all throughout the genitourinary system. We have it in the trigone of the bladder. We have it in that vestibule. We have it in the vagina. And what happens when the vaginal microbiome changes with the loss of estrogen? You go from an acidic pH to a basic pH. So if we have the normal, healthy lactobacillus that's keeping our vagina nice and acidic, that changes when you don't have estrogen. We talked about the physiologic changes. That vaginal microbiome is so important. And so you get this growth of these bacteria that, are known to cause, infections in the vagina, but also in the bladder. And so when that tissue changes, when that thinness becomes more prominent, when the urethra changes, and when you lose that support, right? The estrogen is so important for your collagen production and the connectivity in your connective tissue. So when you have like less elasticity even around the urethra and the muscles change around there, then you get those bacteria that can jump right into the urethra and cause all these UTIs. But the same happens with the urethra when it comes to like the burning. We talked about the vulvar vestibule and how it changes. All of this is related to hormone deficiency. In fact, just as a side note, most of us know these periods of vulnerability that we talked about. Postpartum is another period where you have hormone deficiency, and people have this genitourinary syndrome of hormone deficiency. And it's the same thing that happens to women, a subset of women on chronic birth control use, because it becomes like a syndrome of hormone deficiency. So, the hormones are very important. We have testosterone receptors in the vestibule as well as the vagina. So again, we're losing 50% of that at the time of menopause. So these are all very important to keep the genitourinary system healthy.
Yeah, let's go back and talk about the genital and sexual symptoms of GSM.
So when we talk about sexual symptoms, the way that I like to divide it is I always start with the number one most common sexual symptom that women have, and that's loss of libido. You say, well, what does loss of libido has to do with genital urinary syndrome of menopause? Loss of libido is a downstream effect of sex that hurts like hell. Let's just start like that. When someone comes in and says, I have no libido, I don't think about sex, I don't want sex, I have no desire for sex, and my first question is, well, the last time you had intercourse, how'd it go? Well, it hurt. It really, really hurt. Okay, well, your vagina's not stupid, and your vagina's going to tell your brain, don't go there anymore. So it is all part of it. But the reason that there is so much pain with intercourse is because of the physical changes that I was speaking about earlier. The tissue becomes so thin, it becomes so dry. There is absolutely no lubrication there. So what happens? Sandpaper sex, stabbing pain. And then what happens, which we're going to get to, is the muscles tighten up. But I'm not going to go there because that's Stephanie's job. But the point is that these are absolute physical changes that are causing this to occur. But then we get to orgasm. Just raise your hand if last time you went to your doctor, if he or she asked you if you were able to have an orgasm. And it can't be my patients. None of my patients can. Exactly. We had one hand out of 200 plus women. When a guy goes to his doctor, how often do you think someone asks him about if he's able to have an erection? So we have this big problem, but again, the theme that we keep talking about is they don't ask because if they ask you, are you able to have an orgasm, you say, I'm so glad you asked. I can't have one, and the doctor has nothing to say, but I'm so sorry. They don't know how to help you, so they don't ask. But having difficulty with orgasm occurs in 50%, 50% of women around the time of perimenopause and menopause, and it only gets worse as time goes on. Why? Well, one of the consequences of genital urinary syndrome of menopause, other than the dryness, is you actually get a change in the blood supply. You need decent blood supply for your clitoris to wake up and actually respond to stimulation. You need blood supply for those nerve endings to be healthy and respond. So for that reason, many women are not able to have an orgasm, and we do have fixes for this. We'll get to that. I don't want you to all sit there and go, great, it's over, it's all over, it is not all over. We're going to get to the fixes. But then we look at the non-sexual symptoms, and for a lot of women, sex is just not part of their life, and that's okay, but there are non-sexual symptoms of genital urinary syndrome of menopause. These women who just have this vulvar itching, burning, discomfort. They find that they really don't want to wear jeans or anything because there's always what we kind of call this genital awareness that's really, really unpleasant. And then, of course, as Smeen already talked about, the recurrent urinary infections, the gotta-go feeling, all of that. So it's not just about sex.
Okay, thank you. Stephanie, you're up. Ready? All right, so, there are a lot of us know little to nothing about pelvic floor. So what is it, and what do we need to understand about it a little bit better?
Right, thank you, and there is hope coming. But all the symptoms that you just saw that are also the genitourinary syndromes of menopause, minus the libido issue, are also symptoms of premenopausal and menopausal pelvic floor dysfunction in women. So these muscles run from the pubic bone to the tailbone. They support our organs, they're part of our core. They contracted repeatedly and fast for an orgasm, so there is a way to exercise them that is pleasurable for those of us who hate exercise. And they basically keep us continent during the day under normal circumstances, and they are under autonomic control, which is kind of like our breath, which means that they are being controlled by something out of our control, but we have the ability to override that. For example, when we decide to urinate in an appropriate place, or trying to hold our urination if it's not appropriate. So when these muscles become dysfunctional, it's a big, hot mess. I mean, when I just described all the functions that they have, if this was my company, I would do a reorganization because they're too responsible for too many things. Urinary, bowel, sexual function, our pleasure, our ability to wear clothes, our ability not to have hip and back pain. So when people advance in age, they can become tight, or the muscles can become weak. In most of our menopausal women, I consider my patients like a Prius. They can be a little bit of both. And what's important to know is that over time, our muscles also are hormonally sensitive. We start losing testosterone at 35, just like every other ache and pain can start. The pelvic floor is no different, except for it's a little special because of all these sensitive structures that Dr. Rahman and Dr. Stryker just talked about. When they start to become painful, they are going to cause the muscles to involuntarily contract. This can cause pain, but it can also cause a functional weakness because they can't contract and relax the way that they should to support our bodies. So then we start leaking, then we start having hip and back pain. A huge study that came out recently showed that 95% of women who had low back or hip pain also had pelvic floor dysfunction. But pelvic floor physical therapists are different than orthopedic physical therapists. These things should not have been separated. But if you go to an orthopedic physical therapist for your back, chances are they're going to give you exercises that are bad for your pelvic floor, and all of these symptoms are going to get worse, and it's not going to feel good. So we're working to rectify that.
We're going into treatments, I promise. And there's 6 different things I'm going to cover. We'll make sure we get through them, and so we can also have Q&A. So we know treatments are important. Just quickly, why are they so important?
Well, the reason they're so important is unlike the hot flashes, which might take 10 years or more, they will eventually go away. The brain fog will go away. The insomnia hopefully will go away. But guess what? If you do not treat the vulvar, vaginal, and urinary tract and symptoms, not only are they not go away, it's going to get a whole lot worse. So this is a lifelong issue, but the also good news is you've also heard throughout the morning about how the best time to start hormone therapy is, in your 50s, 60, and all that. That's not the case. With the treatments that we're going to talk about, I have women who've started these treatments when they are 90 and are 100% cured. So it does need to be treated, and it's lifelong. You never stop.
Okay, so let's jump into the first one. Vaginal estrogen, what is it and what can it treat?
Well,
either one of you.
I can start a little bit with vaginal estrogen because, so vaginal estrogen, you've already heard about it. This is a local application of estrogen, which has minimal to no absorption, which means, as you know, any woman can use it, and you can use it lifelong. It does not accumulate over time. But it's not just a cream. We have rings, we have tablets, we have suppositories. There's an oral pill that I think we'll talk about in a little bit. There's a lot of different options. But the one thing I want to mention before I turn it over to Dr. Rahman is that so many women are told, take this cream, put it in your vagina, end of story. No. You want to slather it everywhere. And I'm not even talking about your face. That's a whole different story that we're not going to get to today. But the point is, yes, you start inside your vagina, and then you put a whole bunch more on your vestibule, and then you go north. Put it on your urethra. Your clitoris loves vaginal estrogen. It's going to increase the blood flow. It's going to make it more sensitive. It's going to help those nerve endings wake up. So many people are afraid of it, that they're like, oh, I'm going to take this teeny little dot, and I'm probably going to get dementia, and I'm probably going to have a clot, and I'm probably going to get breast cancer because that's what the product label says. Don't get us started on that. When in fact, that is just not the case. Slather it on.
Well, let's talk about this. I'll have you guys bounce back and forth because you hit some of the myths of it that we think, we hear, are repeated over and over. Myth number 1, vaginal estrogen increases the risk of breast cancer.
Not only does it not increase it, but there's one very good study that shows it actually decreases a little bit. But it does not increase it. And I think everyone on this panel would agree that I cannot think of one medical situation in which someone cannot safely use estrogen. And if you've been told vaginal estrogen, and if you've been told otherwise, not true. We don't have the data to support it.
Right. You just have to ignore that black box warning, which is a whole other story. But
we're all trying to get rid of it. We'll put it that way.
It's been a long journey, but the vaginal estrogen is so critical. Like I said, it is life-saving. We just talked about how UTIs kill women in the beyond midlife, and when you fall from getting up in the middle of the night, it's very life-saving. There's all these different forms we talked about, and vaginal. We're going to talk about another thing is vaginal DHEA, which is called progesterone, or Intrarosa is the name brand, but trade name. but it is DHEA. It's intravaginal suppository that you use. It converts into estrogen and testosterone in the vagina. And so it's really critical because, like I said, we have estrogen receptors in the vagina and the vestibule, but we also have testosterone receptors. So there's a handful of people that will use all sorts of vaginal estrogen all day, and they do not get symptom relief when it comes to having sex. They're still having that introital pain with sex, and that's because they're not getting any testosterone to them, to their vestibule, to that opening, which is really androgen dependent. And so the good thing about DHEA, the studies have shown that when you're using it every night, it'll trickle down into your vestibule and you'll get that. Alternatively, some people we've had to compound estrogen and testosterone as a gel form that you add to the opening, with certain pharmacies that are trusted. So I think that that's also an important topic to realize, because sometimes people don't get the symptom relief they need from vaginal estrogen, from pelvic floor therapy, and the DHEA or the estrogen testosterone gels.
I mean, we're talking about so many different types. So how do you decide, and let's just do this briefly so we can hit the other 5, what to prescribe and at what dose?
I always say whatever the patient's actually going to use is what we have to try to take. And what the insurance covers, right? Like that's big, those are big topics. Like I love the estrogen ring, the estring is what it's called, but it's every 3 months, and it's great for my elderly patients who can't, they don't want to use something down there all the time, and they don't want to shove up anything up there. But the problem is insurance doesn't readily cover it. It's a big problem. I think the cheapest is probably Uvafem or the estrogen tab, actually, that you put into the vagina every Vagifem, Uvafem, and also estradiol cream, estrase cream is also very cheap. But so it really just depends on what the patient's preference is. Like some patients are like, I do not want to do anything now. I'm not sticking anything down there, okay? I'm having urine symptoms only. I'm not doing anything. So maybe they're the ones that need an oral agent that we haven't talked about yet, but it is an oral agent that is used for the genitourinary syndrome of menopause, Osphena.
But I do want to add one thing. First of all, a lot of women are taking systemic estrogen, and it does not necessarily mean that they are going to get the vulvar vaginal support that they need. About 25% of the time that someone is using a transdermal estrogen or an oral estrogen to help with their hot flashes, etc., they are not going to get relief. So they need also to use a local vaginal estrogen. And no, it is not too much estrogen, despite what your pharmacist might tell you when you go to pick it up. It's perfectly fine. The other thing I want to add is, yes, it's personal preference, it's insurance. But a lot of women will choose to use something like the little tablet, the little pill that you put in your vagina, because it's neat, it's clean, it's convenient, it's great. But that's not necessarily going to help your vestibule. So part of it is where do you have the most problem? And we also very often will prescribe dual treatment, meaning someone says, I don't want to use estrogen cream because it's like plopping out on my shoe every time I go for a run. It's really messy. You can put a tablet or a ring in your vagina and then also use the cream for your clitoris, your urethra, and the vestibule. Sometimes you need to get creative.
Absolutely. All right, let's go to testosterone, because we did have a lot of questions about that earlier this morning. Explain what happens to a woman's testosterone after menopause.
So first of all, let's just start by saying testosterone is not a male hormone. It is a human hormone, and it is just as important in women and in men. Please spread the word. So when you make testosterone, you make it from one of two places. You make it in your ovaries, and thank God there's a backup for women who lose their ovaries. We also make it in your adrenal glands. Actually, most of it comes from your adrenal glands. Now, there's this idea that when you go through menopause and there's this precipitous drop in estrogen, the same happens with testosterone. That's actually not the case. You can start to lose your testosterone prior to menopause, and then it gradually continues to go down. Even when you're no longer making estrogen, you are still making some testosterone. It actually comes from a different part of the ovary, so there's the good news. But testosterone is extremely important, not just in things like libido, and we're talking about testosterone receptors in the vagina and the vulva, but we're not getting into a whole discussion about it today, but things in terms of like your muscles, your joints. There's so many other things that testosterone does for both men and women.
All right, Dr. Rahman, what forms does it come in, and what do you recommend?
Testosterone. So we have no FDA, the government hasn't allowed us to have an FDA-approved version of any kind of female testosterone. There's one government in the world that actually has approved testosterone for women. Anyone want to guess? Australia, okay. You've heard this talk before. Okay, so yeah, Australia. So it's called andropheme. That's what they use over there, and you can order it online. But I use Testim usually, like a male version of testosterone at 1%, and you have to titrate it. It's like alchemy. Like we're trying to figure out how to tell patients to use testosterone. So usually, like when a man gets Testim in these tubes, it's 30 tubes that he uses. For 30 days. But that one tube for women is supposed to last us 10 days. So if you get a 30-day supply, which if your pharmacy allows it, I mean, now pharmacies I think have gotten used to like for me to call it in, but for the first year of doing this, it was like fighting them to give patients testosterone, or you'd get these prior authorizations, and it was crazy. But testosterone, it's the one tube lasts 10 days for women. So the one tube has about 5 cc's in it. So you use about half a cc a day, or like I always say, like the size of a plain M&M, or a pea-size amount. I mean, I know it's like strange to tell patients, but you have to kind of put it on, rub it on the back of your thigh, and we kind of see how your symptoms improve. Most societies really recommend testosterone for hypoactive sexual desire disorder, which is what most of us use it for, but we know that there's other benefits. But hypoactive sexual desire or low desire, I want to have sex, but I can't. Like, it's frustrating me. I wish I was having sex, and I'm not. So we use Testim. We have to use a male version. We have to titrate it to 1/10 of what a man uses. And so that's what I usually use for my patients, or sometimes still do the government approved.
But just to be clear, because it's a little bit confusing, what you've been talking about, of course, is using systemic testosterone in order to help with primarily low libido and some of these other things, which is different than what you'd mentioned before, is waking up those testosterone receptors in the vestibule, vulva, and vagina. And for that, we have to go to a compounded product because there is no FDA-approved product. And we do use that particularly in the lower part of the vagina and the vestibule. But one word of caution, a lot of women think, well, I'm just going to put some of that on my clitoris. Don't do that, because it will make your clitoris bigger. A bigger clitoris is not a better clitoris. It is not a more sensitive clitoris. Might I point out that penises are just great big clitorises, and they are way less sensitive. We have 10-fold the number of nerve endings per millimeter. So you have to know where to put it and what your goal is, libido versus lubrication.
A lot of visuals for us today, Dr. Stryker. Okay.
I'm sorry, I didn't hear you.
Test testosterone levels when you start using it?
For systemic, we do. And we talk so often about how it's really not that helpful to test estrogen, and we don't test estrogen, everything that you've already heard. Testosterone is a little different, and we do test it because, number one, we want to know where someone's starting, because even if they're postmenopause, their adrenal glands are still producing. And if someone has a physiologic normal amount of testosterone, we don't want them shaving. We don't want them getting acne, and it's not going to help them. That's the pellet problem that Dr. Larkin also already talked about. So we do follow those levels and a few other little hormone levels too, to predict if you're going to get a good result.
Are female normals the same as male normals?
No. 1/10. Women make 1/10. That's what Dr. Remen was just talking about. 1/10 the amount.
And I think we have.
And we're going to hold the
We're gonna
question
do
now.
questions right at the end. That's okay. So DHEA, we really kind of hit on that already, right? Do you want to just briefly give us a one-line on that?
DHA is precursor to both estrogen and testosterone in the cells. When it gets into the vagina, they come in suppository forms. The FDA-approved version does. And when you put it in the vagina, it converts into estrogen and testosterone into those cells. Studies have shown it dribbles down into the vestibule, so you get a 2-for-1 in that respect. It just takes a little bit longer to get there. Okay. But yeah, very helpful.
Thank you. Stephanie, a lot of women still have pain, even upon using vaginal estrogen and or DHEA. What do you recommend at that point, and the reason there could still be pain?
Thank you. Well, one of the reasons I'm here is because pelvic floor muscles can cause pain. But one of the first things that we're catching in the clinic, if patients are referred to us by a gynecologist who maybe gave them vaginal estrogen, the same things that Dr. Stryken and Raman talked about, they may be putting it in their vagina and not on their vestibule. And they may not be going back to that doctor for another year because they had their pap smear. But now I think my vaginal estrogen isn't working because I still have painful sex, irritated bladder symptoms, and I don't feel good. So it's important to know from YPT PTs have to know so much about the medical side is because we're going to see them every week to treat the painful muscles that they have and some of the disorganization in their body. But half of what we're able to do is explain you don't use vaginal estrogen for 2 weeks and expect that that's going to work, especially if you were symptomatic GSM before getting the medications that they talked about. So I think one of our very important roles as physical therapists is to be supportive and make sure they know how to put the topicals around their urethra, because a lot of people here put it externally and they're putting it on their leg and their labia. To us medical professionals, externally means distal to a hymen. To a patient, it may mean the labia. And so that's just something that I see over and over again that's easily remedied, but then we need some reassurance that this is going to take a little longer than initially thought. In pelvic floor physical therapy, we are examining the ribs, the muscles, the connective tissue, and the nerves from the ribs down. So this doesn't include just a transvaginal pelvic floor exam, but also making sure the pelvic floor muscles are coordinating with the rest of their core and their breath, which tends to get it interrupted as early in many women as childbirth. So in many other countries with socialized medicine, women are required to do postpartum physical therapy, and this is the first opportunity that women are really set up to have a pelvic floor disorder that may not be bothersome for enough into their life until they get into menopause and all these other things start happening too. So at that point, we really have to examine not just a Kegel, not strength and endurance, but is there pain? And if there's pain, we use manual therapy techniques to reduce the pain before we try to do things to increase muscle tone, which could make a painful muscle more sore. There's also various neuropathic issues that can occur in the pelvis, in the genitofemoral, ilioinguinal, and especially the pudendal nerve, which innervates everything. So there's often injuries to the pudendal nerve during pelvic organ prolapse repair surgeries. It could have started after postpartum, or there can be some mechanical causes. Because we also talked about the clitoris and the pudendal nerve goes there, I want to also discuss female vulvar hygiene. So as we age, the size of the clitoris starts to shrink. With that happening, the hood of the clitoris can start to stick to the clitoris itself. If we get discharged smegma, if there was a cleared vaginal fungal infection but still some issues with the skin, this can lead to the clitoral hood fusing on top of the clitoris. And we can easily prevent that by retracting the clitoral hood in the shower every time we wash, just to make sure we're getting water under there and no adhesions are forming, or these things that are being called keratin pearls. I can never look at that piece of jewelry again, now that this is a prolific thing.
You don't want those kind of pearls.
No, don't want those pearls. But so many people develop this clitoral pain and are coming to physical therapy when really it's a local pathology and not even referred from the muscles or the pudendal nerve, as I mentioned. So one of the supportive roles we can play as physical therapists is in the differential diagnosis. Is there a local pathology? Is there a hormone deficiency that we can see visually? Do we think there's an infection that hasn't really been cleared by the standard gynecologist? Or is it our muscles that are causing that? Because these muscles and tissues, again, cause all the same symptoms except for the libido issue that I just mentioned. Now, in addition to the diminished orgasm that we started to talk about, the hormone changes and supplementation are really going to help get everything to come back. But if there's pelvic floor muscle weakness or pelvic floor dyssynergia, your ability to have a rapid, pleasurable muscle contraction orgasm is going to be different. So that's one of the side benefits that we can provide. Many people aren't coming to us because their orgasms are diminished. They have all these other symptoms, but a side benefit may be that all of a sudden that's coming back stronger, faster, or harder, and no one is complaining about that.
Right. How many sessions approximately?
So this varies, the amount of sessions. If people are just coming in for a checkup because you've heard this lecture, we're going to identify the impairments and have short-term goals to reduce those, and then longer-term goals that are going to be your functional symptom outcomes. You don't want to leak, you don't want to have irritated bladder symptoms, you want sex to be pleasurable. The impairment-based goals can take 4 to 12 weeks, roughly. If I'm seeing somebody who has all of this and a severe pelvic pain condition, sometimes that can take longer, and the appointments are usually weekly for 1 hour.
Okay.
And by the way, no soap on the clitoris. Just water.
Just water on the clitoris.
I want to be clear, because hygiene's
I said
important,
water.
but no soap.
No soap.
No products, no feminine hygiene
But everyone
stuff.
can retract their clitoral hood and see.
Right,
And that will also help with orgasm function. If it's starting to phimose without pain, you're going to have hyposensitivity of the clitoris.
All right, number 5. Good. Dr. Stryker's on the edge of her chair here. Talk to me about this.
One of my favorite topics. We're talking vibrators.
Yes, we are.
So, I could do this one all day, but I'll keep it short, right? You know, we always think of a vibrator as being a toy, and it is. Toys are something to have more fun, but I refer to a vibrator as a tool because a toy is to make something pleasurable, a tool is to make it possible. And what we now know, I mentioned that over 50% of women postmenopause are not able to have orgasms because of the decrease in blood flow, because of the changes that occur, but also because of changes in nerve endings. Particularly, this can happen in any woman as a consequence of menopause and aging, but when we look at certain medical conditions like diabetes and vascular disease, you can have nerve endings that are no longer responsive. You've all heard of foot neuropathy. With diabetics, you can have a clitoral neuropathy, and most endocrinologists are not chatting about that at your appointment. So this is the deal, and this is the short answer to a very interesting topic, is you have different kind of nerve endings in the clitoris. Some respond to soft touch, some respond to pressure, some to respond to vibration. The nerve endings, and you know where I'm going with this, the nerve endings that respond to vibration are bigger, and they have a protective myelin sheath. So what that means is as you age, all the things that were your tried and true methods to have an orgasm when you were 30 or 40, if suddenly they're not working anymore, it's because those nerve endings are out of business. They've had it. But thank the Lord, the nerve endings that respond to vibration, they're going to keep on going. And that is why women will have an orgasm with a vibrator when nothing else is working. So if this is a tool, I tell medical students, don't ever say to a patient, do you have a vibrator when you're taking a history? What you say is, when you use your vibrator, because we have to normalize it.
Well, and that goes to my next question, Dr. Rahman, because how do you communicate that with your partners? If you have a partner and you don't want them to feel, is it me? What's going on? How do you communicate a change of need?
Yeah, I mean, I think it's important. Communication's like the essence of really having a pleasurable sex life. So I feel like if you can't talk to them, it's not a me problem, it's really a we problem, right? Like we both have to work on, you know, you might have erectile dysfunction if you're having sex with a man, or, you know, or Peyronie's disease or whatever. And so just like you would want him to communicate with you, if you're heterosexual, you want him to communicate with you, you'd want the same, he would want the same. And most men really want to pleasure their partner. Most partners want that pleasure for their partners. And so I think it's just having them understand. That's why I think when people listen to our podcast or go on social media, it's a lot of them are men that are listening, or partners of people that are there listening to the information that we're giving, because it's so important for them to hear, okay, it's not actually just that she's not interested in me anymore. It's not that she's, you know, unless it's a true problem with your husband or spouse or whoever it is. You know, I think the communication is of the essence to understand that these are processes that are happening because of a hormone deficiency, and we're trying to work on them, but I do need to augment this. And it's not about you, it's about us.
Okay, I want to get to Q&A because I'm assuming you guys have a lot of questions, but I want to ask this one question. Oh, sorry, I lost my place totally. Oh, over-the-counter moisturizer and lubes. Let's hit on that real fast.
Okay, just
to treat
quickly.
GSM.
Yeah, the moisturizers are great. They're like, you're supposed to use them like twice a week. Just when you think, my patients always say that their vagina is so high maintenance now, but it's true. Like, you have to do a lot to really get it to a point where you can actually enjoy sex and, you know, diminish, you know, urinary symptoms and all of that. So hyaluronic acid-based moisturizers are something great to use about twice a week. Just like you moisturize your face, you want to moisturize your vagina. And then lubricants, whether they're water-based, silicone-based, you know, whatever you're using from your house, are very important as well. Some people might be irritated by them. I think most patients really like the silicone-based ones because they're really, they last longer, more slippery and all that stuff, which are really important.
Perfect. All right. Let's get questions. If you guys want to put your hands up, we'll get the mic over to you right away. Oh, sorry. Okay.
And am I open? Here, there we go.
Hi, thanks so much for being here. I'm a fitness professional that works with pelvic floor therapists, and so I reintroduce women back into fitness after pelvic floor therapy, whether they're there for prenatal, postnatal, or menopausal care. So thank you for being here. Ladies, get to know your pelvic floor. It's really, really important. And the other comment is that we should normalize toys and tools and whatever else. I had gone into my care provider who really blew off not, being able to achieve an orgasm. And my husband, who's here today, he's a physician, but he went online. He's like, pick out 50 toys, we'll buy them, we'll figure it out. So it's really important to just have a good partner and to be honest and open.
Can I just add something super quick with that, because we haven't talked about it? Sex therapy. We have not, and of course Dr. Kingsbury, but I cannot emphasize enough for couples who love each other, they have a great relationship, everything is fine, but their relationship, their sex life has been sabotaged by everything we've been talking about. We can fix the tissue, we can fix the muscles, but sex therapy is so important from someone who knows what they're doing.
Biopsychosocial is really important for these sexual medicine concerns. So that's why, we can do the biology, but we need someone else to use the other stuff.
Thank you.
Have fun. We have a question here. Okay.
Hi. Dr. Stryker, when you said that you can't think of any situation where vaginal estrogen couldn't be used, what about bladder cancer?
There's not a lot of data. Let me just start with that. But there's no data the absence of data is not the same as data. Let's put it that way. But I'm not aware of any reason to not use it with bladder cancer. Is anyone else, any other panelists? Yeah, I'm not aware of any data that says it's a problem.
Then one quick question on red light therapy devices for vaginal health. Yay or nay?
For what kind of devices?
Red light therapy.
I have seen no data, so I would not give that a thumbs up.
Okay.
We're all very data driven here, Show us the data.
Dr. Stryker, you forgot to mention osmolality and lubricants. Stop buying cheap lubes. Make sure that you turn.
All right, I'll give you the quick this. When we talk about lubricants, number one, what you need to realize is that lubricants do not change the tissue. They just grease the skids. They make it more slippery. But you don't want to use a lube that's going to irritate the vaginal walls. And what we now know is not silicone. We're all lovers of silicone lubes. Those are great. But the water-based lubes, particularly the ones that are the number one thing on the shelf, that are the cheapest, that start with some letters, okay? The osmolality is sky high, and we have data that shows it actually eats away at the vaginal tissue, eats away at it. So you want a low osmolality lubricant, and people always, I have a list in my podcasts and books and all of that, but the way to know is if they don't tell you what it is, it's real high. It's real high. The people that have low osmolality are going to brag about it.
I've had breast cancer, so I'd like to know if vaginal estrogen works in the same way for women who are suppressing their ovaries and actively taking aromatase inhibitors.
The answer is, as far as we know, yes, but not a lot of data, specifically in aromatase inhibitors.
That
Great
is
question.
a tough one. Aromatase inhibitors, that really destroys, I think, the vulvovaginal area in general. So it's really, really hard to get good treatment.
And the other issue, of course, is women who've had radiation.
Yes.
So many women who've had radiation to the pelvis for anal cancer, rectal cancer, cervical cancers. There's a lot of cancers that you end up with radiation. Radiation is not good to the tissues. So, but it's all, we can still do stuff. The one caveat I will say is the sooner you start, the better. I talked about how you can fix this stuff years later, radiation. You want to get on board with this really fast.
Thank you so much. This has been fantastic. I do have a question regarding if the majority of your symptoms are vaginal, would you also suggest doing the estrogen patch and progesterone or just vaginal cream?
It's two different, with shared decision making, we hear this term a lot, it's what is your goal? What is your goal? So it's not one or the other. It's not both for everybody. It's what are your goals, and then you get your, what I call your menopause master plan. How you're going to figure it all out. But you can use them both together. That's the most important thing.
Hi, my question is regarding the DHEA cream. Can it just be purchased over the counter, or do you need a prescription
DHEA is a
for it?
prescription, so it's an FDA-approved product. It's prosterone, and the trade name is Intrarosa, and it's a suppository actually that you use nightly. And so, unfortunately, insurances make it very difficult to get it covered many times, but it is by prescription.
And you can get a compounded version that is a cream, but you still need a prescription.
We have one on this side.
Hi, I'm 43 and not experiencing any of this, and this was very scary, I just wanted to say. But so I'm wondering, is there a role? It sounded like when you were talking about pelvic floor or the vaginal estrogen, of using it before you have any symptoms? Like, when should you start?
For pelvic floor PT, I think everybody should have an evaluation after birth and as they enter perimenopause and menopause, because if there is dysfunction, it may not be symptomatic yet. And so it's quickly fixable, just like if you have an ankle sprain or a knee sprain. So I do think it should be standard of care, and hopefully it will be soon. Was there hormone questions with that too that you wanted to?
Oh, yeah, in perimenopause, I often will, go ahead and prescribe vaginal estrogen or DHEA, because, perimenopause, again, with these big hormone fluctuations, like when you feel like there's a lot of estrogen, you might not feel it, but there might be times or months where your levels are on the lower side and you do feel a little irritation or pain with sex or difficulty. And so, this is a chronic progressive condition. If you don't treat it, it may not bother you now, but for most patients, at some point it will. So I like to get ahead of the eight ball and try to get them going with that.
So my question, I'm so thankful for all of this, for all of us sort of middle life women. I'm just weeping here for my mom and my aunt. And fortunately, they're healthy, but learning about the cardiac benefits of estrogen and the bone benefits and the reducing UTI, all of that. I mean, is it appropriate to suggest that they're 80 and 77, basically healthy, that they speak to their doctor? Is there a hormone replacement that you don't start until you're 75?
Yeah.
I mean, what is?
So the local vaginal stuff, honestly, you can start anytime if she's symptomatic. Not everybody is. When you're talking systemic, and I think the hormone panel really addressed that, it's really very individual, and you have to know what someone's cardiac status is, but it's not off the table. There was a very, very good study that just came out with 10 million women who were taking hormone therapy over the age of 60 who did very well, but taking it through your 60s, continuing it, is different than starting it. Totally different, and that is a very individual thing. I actually have a podcast episode specifically about starting after 65, which is like from 3 weeks ago, with Dr. Jim Simon, a colleague of ours who we all adore, that really talks about how do you evaluate someone and when is it okay.
Any other questions?
I think we have some over here.
Hi, just want to thank you all so much for all of this. I'm from Lexington, Kentucky, and I'm a provider at a very large women's health center. The number one complaint that women have when they come in is they'll start head to toe, hot flashes, night sweats, sleep. I mean, they hit all the way down. But then they'll start weeping when it comes to intimacy. They no longer have any sex drive. Sex is painful, and it's so sad when they say, my husband's going to leave me because I no longer desire sex. I mean, it's just, you sit there and you listen to them, and it just breaks their heart, breaks my heart. So testosterone, that's one of the things I want to touch on, where it's not FDA approved for us. We can use compound facilities. We can do the testosterone creams. But what do you do for the patients that their testosterone levels are not rising? Because, there's that absorption. We work very closely with a compound pharmacy. So we know our pharmacists, and they'll come in and they'll talk to our providers. And they'll change around the carrier of the cream. With you using the gel, you said again that you do the 5. Do you just do the gel for 10 days, or how are you?
Oh, no. This is every day. But I also want to mention that when you look at how well testosterone works in postmenopause women, you're looking at best a 50% improvement rate. And that speaks to the fact that libido is so multifactorial. And we haven't even touched on all of the reasons that can impact on libido. So the critical thing, and I know you keep hearing this all day long, but you have to see an expert, someone who really knows this stuff. And unfortunately, most gynecologists, most primary care doctors have not been trained. But there are many, many things that can be done to help with that situation, but I don't want people to walk out of here thinking that testosterone is the be all and the end all.
One of the things is we have pelvic floor physical therapists that we absolutely love. They're amazing, and what you all do is amazing. It's great.
I call them my magicians.
Most of the women that go, they're like, oh my gosh, I love this.
Yeah.
And so does my husband. So it's great for that. So it's a combination of everything. But when you're using pelvic floor, insurance won't pay for Interosa. We're so limited on what we can do for patients. That's what I was wondering if it was a 10-day, how are you doing that? Because mostly we just do the compounded testosterone creams.
So it's not a 10, I meant saying that one tube lasts 10 days, but if you have 30 tubes, it'll last you 300 days. So you really just need to give them 1 month supply. It'll last them almost a year. But if at 6 months they're not really having a change in their libido or sexual function, then they can discontinue it. And you have to bring in sex therapy. We can use off-label use of some of the premenopausal medications that have been tested in postmenopause that will increase your dopamine or norepinephrine, the injectables, or the pill. And so those we can use off-label. Just for the providers in the room who are interested in learning more about sexual function, we do have an organization, the International Society for the Study of Women's Sexual Health, ISWISH, and we have fall courses, and we teach other clinicians how to treat sexual pain and sexual dysfunction.
But one last thing that has not come up today that I think is important to mention when we talk about sexual function is how often do women go to their doctors who are 50, 60 years old, they say sex hurts, and maybe if they're lucky, they're given a prescription for local vaginal estrogen, and then it doesn't work. So they think, okay, well, it's not working. It's not working because in most cases that woman was never examined. These things are being prescribed without an exam. She might have an entirely different condition. I have seen vulvar cancers, lichen sclerosis, pelvic floor issues. We all have a long list. So please, if you can start with a local vaginal estrogen, if it's not working, you need to be examined by someone who knows what they're doing.
And that is a good point. There are so many inflammatory vulvar skin conditions that really, increase. We see it. We see more symptoms, at least, in pre-menarche and post-menopause because of the estrogen deficiencies. So we really need to be cognizant of the vulvar architecture too.
Okay, a question over there.
Hi, this is loud, sorry. Hi, I'm a pelvic floor therapist, so the whole day has been amazing. But my question is, as a pelvic floor therapist, I spend a lot of time educating women on what their options are, right? And in our area, we don't have access to great providers. Last night, I had a 30-minute discussion with a local provider who basically mansplained hormones to me and told me that my patient who's having night sweats is estrogen dominant and needs to say no more. As a pelvic health provider, how do I talk to doctors in my area and respectfully, because I really wanted to tell him a lot of things that I...
It's hopeless. You don't. Don't waste your time.
What do I do?
I'm sorry. It's a waste of time. If you had something really seriously wrong with a family member, with a kid, you would find an expert. You don't try and explain it to the expert that happens to be the so-called expert. So yes, you go to the Menopause Society website, you put in your zip code, you can find someone who has an interest. Full disclosure, I work with MIDI that has clinicians that you can do by telehealth all over the country that specialize in menopause. You can find an expert. But you really want to think you're going to get anywhere mansplaining, this guy who's mansplaining to you? I don't think so.
All right. But I want to touch on that because that goes back to the point that someone asked about sending in their mother and grandmother. Like the panel that you heard here today would be giving anybody very different experience than the person that's mansplaining to you. And it almost can undermine us as physical therapists because then they're acting like I'm uninformed. So I'll start out by sending them to Dr. Mary Claire's Instagram or other Instagrams and the societies if they're not going to bother to read the North American Menopause Society. And if that doesn't work, we're finding another doctor. And I can give them my 7 pages of credentials to explain why I'm able to talk about this. And that's it. Thank you to these people because that's why.
All right, well, thank you all very much. Thank you.
Thank you to an amazing panel. Fantastic, absolutely fantastic. Thank you to all of you. We're not done quite yet. We have a few more minutes. Just want to thank everybody. What did you guys think? Yeah? Should we do this again? Should we do it in other cities? Right? I think that one of the things that I'm struck with what happened here today was that people shared their stories and were okay with being vulnerable. And I think that you also heard providers telling their stories, right? Oftentimes we think about doctors and we think about, oh, we're sort of scared to go to them. We think like they have it all together and they, right, like they know what's going on and they're asymptomatic with everything. And that's not the case, right? And I think that sharing our stories can help other people, sharing what works, what doesn't work, what doctor to go to. Not everyone's the same. I think we all have to remember that. What works for one person doesn't necessarily work for another person. As Dr. Noble, our chief medical advisor, says, get the information and then you do you, okay? So I think that's also really, really important. And I know for myself, as the founder of Let's Talk Menopause, I started this organization, this nonprofit organization, because I knew that women were not getting the care that they need, including myself as a breast cancer survivor. Oophorectomy, went into sudden menopause, drowning in symptoms, and I was running a partial hospitalization program for pregnant and postpartum women experiencing severe mood and anxiety disorders. And so, talk about symptoms that happens after that. The woman with breast cancer over there on an aromatase inhibitor and having multiple hot flashes a day. And I want to say to the person over here who was 43, and I think it was the one who was 43, and she was like, oh my gosh, I'm scared. Like, you guys are scaring me, right? So I want to also say that I am 57 years old. I don't apologize anymore. I don't say, oh my God, I can't believe I'm 57. Oh my God, I'm getting so old. I don't say that anymore. I am 57 years old, and I'm super proud of it. I'm super proud of Let's Talk Menopause and what we've done. I'm super proud of myself because I actually told my story. And as a therapist, I was telling people before that as a therapist, I was trained in the 80s and 90s. We were trained not to tell anybody anything. I mean, it was kind of a terrible form of therapy. Really. Therapy has gotten so much better. I think we talked about the CBT. I have now become fully a skills-based therapist. And it's so helpful. My patients really benefit from that. And also, medication can be really helpful too. It's not one or the other. Sometimes it's and, the power of and. And I think I want to just say that about being scared about menopause or what's going to happen is you may not feel like you did when you were 30 or 20. And guess what? You also can feel pretty damn good. And you can, right? You can actually feel your best self. Because you know what? I started an organization because you know what? I just said, like, fuck it, who cares? I don't care what anybody else thinks anymore, right? Isn't that great to get to that point where we just don't care what other people think? It's great. Anyway, we have a ton of people to thank. Let's hand it to Tamsen Fadal and Dr. Judith Joseph, our wonderful hosts and all of the work that they do to improve care for women. And you're absolutely fantastic. And then I'm going to go through the panelists, and please, I hope I don't forget. Oh, the names are here. I won't forget you guys. Okay, Dr. Monica Christmas, thank you so much. Dr. Lisa Larkin. And Dr. Lisa Larkin, if you go onto our website, she's going to be doing one on menopause and breast cancer because it really is something that's super important, and it's nuanced, and it's individualized care. Okay, so I think if you guys have a couple of takeaways, you don't need to suffer. Individualized care. Vaginal estrogen for life. What else? What are the other takeaways? I don't know. I'm getting distracted. Dr. Sharon Malone. A true friend and advocate. Dr. Cheryl Kingsburg. Dr. Pauline Mackey, how did she get here today with having an engine, I can't even fathom it. Stephanie Prendergast, physical therapist. Dr. Samin Rahman. Dr. Mary Claire Haver. And of course, Dr. Lauren Stryker. Wasn't that last panel just fantastic? I mean, seriously, where do you go, right, where you talk about women's sex? It doesn't happen that often, right? So to have this, amazing panel. So we also want to thank our sponsors. We are a nonprofit organization, and as you can see, we need money in order to do these things, and these wonderful sponsors helped us with that. But as you can see, we're not tied to any programming, if that makes sense, right? So it's really, really, really important, though, that we have sponsors, we have partners. We thank all of our partners. I want to add my sister. You have a little in your bag. You have a little laptop sticker. That's from Wall Dressed Up. That's my sister's business. It's fantastic. She does all sorts of pictures. All of those people there, Care Beauty, Convene. Oh, thank you to Convene. The staff over here was fantastic. This room is amazing. And the tech people that helped us with all of this were absolutely unbelievable. So thank you so much. And of course, all the people that, helped get this event together. I think that's it. Survey. Okay, so if everyone right now can just go to this QR code. We were going to do this whole thing with Slido and polls and whatever. We decided to be more personal. But if everyone go here, there's a survey on there, and fill out the survey. This is actually how we improve our programming. So in next year, in Menoposium 2025, and maybe we'll even start doing them every half year, but we want to hear from you guys. What do you want us to do? What information are you seeking? And so please do that. Visit our website. Tag us on social media. And that's it. Thank you, everyone, so much. And thank you again to our panelists and to Convene.